All right. So today is June 1st. How about that? I just realized that. It's like we're done with May already. We're into June. It's kind of scary. I didn't realize that we're at like almost halfway through the year. Christmas is coming fast, y'all. That's all I'm saying. We're going to talk about range of motion today. I know it's crazy, right? I swear these years go faster and faster the older I get. I think it's because it keeps pushing me further and further in my age. So we're going to talk about therapeutic exercises and basic range of motion today. Because if we don't get basic range of motion, we won't get manual muscle testing and kinese. We also won't get goniometry and kinese. So we'll talk about this a little bit today. So we're going to talk about some key terms here: adhesions, collagens, contractures, creep phenomena. We'll talk through all of these because I'm guessing a few of these, at least, any of these here that you absolutely do not have a clue about? Any of those you don't remember ever seeing?
Creep phenomenon.
Creep phenomena, that's what I figured. Good, okay. Muscle spindles, Diana says.
Low.
Don't know muscle spindles. You probably don't know Golgi tendon organs either. We're going to talk about all these fun terms today because this deals with range of motion of the muscles and basically moving the joints around. So remember, pretty much most of our body, right? Bones, muscles, tendons, all that stuff is made up of connective tissue. And you can actually get connective tissue disorders, right? Does anyone know of an example of a connective tissue disorder that would cause problems with your connective tissues? Maybe where your hands kind of get gnarled up. Rheumatoid arthritis, good, right? Yeah, right? That's a connective tissue. Lupus is another big connective tissue disorder. And so you got to think about that. Your body is pretty much made up of connective tissue. And if your body's not made up of connective tissue and it starts getting inflamed and everything like that, it's definitely caused all kinds of problems. So connective tissue makes up all of us, right? We have our collagen and which leads to tropocollagen, which leads to collagen, which helps build up our bones, tendons, muscles, skin, cartilage, and joints. It provides our strength needed to withstand tension and force during movement. There are three primary types of collagen, right? We have type 1, type 2, type 3. Gee, they couldn't have made that any easier for us, right? Type 1 collagen is that really thick, fibrous collagen. Type 2 is thinner and has a little bit less tensile strength. And then type 3 is kind of the collagen we'll find in organs and also is used for wound repair. Elastin plays part with collagen to help. It's present in tendons, but it also increases and comes in when we're rebuilding tissue. So like if you have a stretch where you tear a muscle, elastin is going to come in and help rebuild. It's a protein that comes in and helps rebuild that muscle so that you actually maintain flexibility even if you've got that tear. So all of that's going to come into play, right? The collagen and the buildup of all that collagen is going to build us our tissue itself. So when we have a stress on a muscle, right? So if I'm holding a dumbbell in this hand, I'm putting a stress on my bicep. The more I stress that, the harder it's going to get for me to resist that. So the more weight either I put in here or the longer I create my force arm, right? That's going to tie into playing with those basic machines and stuff like that. So stress is the load we put on a muscle. Strain is the deformation of that muscle. So we have this thing called the stress strain load phenomenon, where when we increase stress, it's going to strain the muscle, cause it to deform, which is going to increase the overall load or work of the muscle to be done. If you look at the chart down here, right, this is kind of a chart that looks more complicated than it really is, right? So the chart is saying as your strain goes up, right? So as the deformation of that muscle goes up, right, the stress is also going up with it. So this way is our strain. As our strain goes up, our stress level is going to go up with it. So the more load we put on a muscle, the more strain we're going to put on that muscle until we reach a point where that muscle can no longer hold it. And at that point, we have a couple of different options. That muscle can just rip off, and then we can end up tearing that muscle. or the muscle has some safeguards in it to prevent tearing, which we'll talk about with the Golgi tendon organs and with the muscle spindles. So the good news is we have some built-in protection in our muscles that do help protect us from overall tearing a muscle, but tears still happen. So viscoelasticity is the elasticity we exhibit in our muscles, right? Visco meaning having some fluid, elasticity having the ability to return to normal, right? We always think of elasticity, right, in the terms of stretching. So I've got a good old mask here on my desk. We always think of these rubber bands as being elastic because they stretch, but they're actually elastic because they return to their original shape, not necessarily because they stretch. The more we deform them, the more we stretch them, the less they're likely to return to the original shape. And some of you may have some older masks that you've worn since the start of the pandemic that just don't fit that right anymore. They don't go around, maybe they're too loose around the ears now, or whatever it may be. That's because those actual tendons or those pulleys on that actual mask have now stretched out beyond their normal shape. Viscosity is the ability to resist change, and it's usually due to fluid. When you hear of viscosity, a lot of times what I think of is oil in your car, because oil is measured in viscosity. And the oil in your car, when you put oil in your engine, the job of the oil is to lubricate all the cylinders in your car to keep your car from breaking down. It resists the change in the shape of your pistons and everything inside your car. Same idea here with your muscles. Viscosity is going to help resist that overall change in order to lessen that pull and that shearing force so the muscles don't rip off. The slower the stretch on a muscle, the greater overall strain. But the longer that stretch will last for you, meaning we'll talk about that in a bit, talking about which stretches are kind of a little bit better for stretching and which ones are better for, long-term stretching versus short-term stretching. The faster that you do stretching, so if you do ballistic, which we'll talk about, which is kind of a bouncy stretching, you'll get smaller elongations and it'll take longer to reach out to that greater strain length. So this leads into this thing called the creep phenomenon. And literally, there is whole books written on the creep phenomenon. The good news is you only have to know this basic kind of layout of what the creep phenomenon is. What it says is gradual increase in tissue length that occurs when maintaining a constant stress or force. So what is that saying? So let's say I have a contracted biceps because maybe I had a stroke and my arm's stuck in this position here. If I put a weight in my hand, if I'm a patient, and I just hold on to that weight, overall, what's going to happen?
It's going to start to stretch out.
Yeah, it's going to, even if I'm locked this way right now, if I just hold it for 10 or 15 minutes, eventually I might be here, right? Just because that strength, that length is going to happen because there's a constant force going down this way. Thank you. So as that strain goes along there, right, the longer we hold it, the greater the deformation. So does that mean that, let's say we have a patient who had a stroke 20 years ago. They've never got physical therapy, and they come into physical therapy and they're going to see John and they're like, all right, John, stretch me out. And they're like this. Is that patient probably likely to ever get back to full normal?
No.
No, right? Because at that point, the muscles have been replaced with fibrous tissue, right? If you actually were able to take an MRI of that muscle, it's going to structurally look different. Same idea if you look at a kid who has muscular dystrophy. Their muscles structurally look different. The muscle itself starts being replaced with adipose in the case of muscular dystrophy, which means that it's not going to have that same tensile strength, right? But now, let's say I had my stroke 3 days ago, and now you're seeing me in the hospital. Now, yeah, because my muscles haven't had that time to break down, you can use some of the creep phenomena here to help me gain some of my flexibility back. We're going to talk, do you think there are some times where maybe with a stroke patient, we might not want to gain our flexibility back? Or do we always want to get flexibility back? What do you think?
I would assume you want flexibility back.
Okay, for the most part, yep. Now, there are times, so there's a specific grip we'll talk about, especially with Dr. Reskin next semester, called Tenodesa Script. And what it is if I have my hand out like this, if I extend my hand back, my fingers naturally kind of flex. You see how that kind of happens? So because that's happening, we can actually let the fingers contract a little bit, and therefore they can actually extend back and get a little bit of a grip so they could grab things like silverware to feed themselves if they're never going to gain full use of that arm back. So they can use a little bit of a contracture to their benefit, but it's pretty rare. So stress relaxation now comes along and says the material experiences a constant strain, no change in length is produced. That is, if a muscle is held at a certain length over time, reduce stress but not change the length. Basically saying that if we want to relax the muscle, we're going to take some of that strain or that load off of the muscle, right? Because if I'm holding that constant load, that muscle is going to be contracting against that load constantly, right? So if I had that stroke, do I want them to hold a 20-pound dumbbell? Probably not, because that's going to put too much of a strain on that bicep. We want a lower weight in their hand, maybe a 1 or a 5-pound dumbbell, so that they're relaxed while holding it. So we get the creep phenomenon going in, and also forcing relaxation of that muscle so it's not constantly fighting it and going to spasticity. So what does temperature do to muscles? Well, the higher the temperature increases the rate of creep, which means it increases the ability of the muscle to stretch. There is a therapeutic limit, which is about 45 degrees Celsius. And remember that human body temperature is about 37. So 45 degrees Celsius sounds about like where we keep what in the therapy clinic? What do you think we keep around that temperature in the therapy clinic? Yeah, moist hot packs, exactly, right? Because there's a benefit curve that goes that once we go over that 45, we get a diminishing rate of return. And at that point, we're using more energy to heat up the hot packs than we're actually going to get out of the hot packs. Exactly. So the higher the temperature we get, so the closer we get to that 45, the greater the degree of elongation with stress before you end up with tissue failure. What's that saying? Well, if I increase the temperature of the person holding that dumbbell, say again, I've got a stroke and this arm's contracted. If I put a hot pack here along with that stress, that load, I'm actually going to get a greater amount of elongation because the muscle is going to be able to stretch because the elastin in it is going to spread apart and allow things to stretch a lot better. You guys probably know this because you should find that it's easier to stretch your legs after you've warmed up a little bit, right? After you've kind of done a little bit of exercise and gotten your muscles kind of ready to move and moving around, right? Whereas if you just go straight into stretching, it's a lot harder. In the martial arts, when we began our classes, we usually started off with some jumping jacks, some push-ups, some sit-ups, just to kind of get our cardiovascular going so our body naturally warmed up, so that when we went into stretching, we didn't tear a muscle. So what it's saying is to stretch out connective tissue structure, heat it, and use a load over long periods of time to create that creep phenomenon, right? So we're going to allow that whole thing to go so we get a greater period of time and greater stretch out of it. I don't know why we don't do this more in the clinic. We use hot pack at the very beginning of therapy and put it on them, and then we go to stretch them once they're off the hot pack. We probably could get more out of that moist hot pack if we stretch them while they're on the hot pack and allow them to actually get some benefit out of it. There's also a relaxation factor, right? You guys felt it with the hot pack. Didn't it kind of relax you a little bit and allow things to go a little bit easier when you're sitting on that hot pack? Right? Yeah, right. It's like every time I have a back injury, my back hurts, put that hot pack on, I'm in heaven. Oh. Right? I called it. I see that. So flexibility is this topic, and it's very ambiguous to most people, but flexibility is the ability of muscle to relax and yield to stretch force. It's the ability to move muscles and joints through full range of motion. We have a natural flexibility, and then we have an ability to gain more flexibility. When I started, again, I'm going to relate this a lot back to the martial arts. When I started in the martial arts, our instructor always said, well, you can kick to the body, but if you kick to the head, you can do more damage by kicking to the head. And I'm like, yeah, right. My legs don't go that high. Just doesn't happen. And he's like, well, the more flexible you get, the more you'll be able to get those legs higher to kick. I didn't believe him. Personally, I didn't believe I was ever going to get that flexible, but it happened. It took a long time. Flexibility can apply to all connective tissues, so not only muscles, but ligaments, and it can also apply to bones. Bones have a certain flexibility to them, right? There's a certain force you can bend a bone before it actually snaps, especially when you're talking about somebody like a kid, right? Does anyone know what type that fracture that is that we hear about kids getting a lot? That's a little different than what adults get. Green stick. Yeah, right. And why do we call it that? Well, because when an adult bone breaks, it kind of snaps, right? You get those clean, clear edges where that bone snaps. When a kid's bone break, it kind of splinters, almost like a green tree stick, like you pulled off a fresh branch off a tree and break it. It doesn't break as smoothly as a nice, brown stick. And the big joke there is what's brown and looks like brown and sticky, a stick, right? Yeah, I got a couple, maybe I got to laugh out of one or two of you. So when we do flexibility or stretching, we can stretch things statically or dynamically. And what you'll find is almost all of our activity we do in Therex, we can either do statically or we can do dynamically, meaning we can do them standing still, or we can do them with movement dynamically, right? We can do balance statically, or we can do balance dynamically with movement. So how do we measure the flexibility of a person? Well, goniometry. We're going to talk about that. We're going to go through different types of goniometers in kinesiology. The main thing that you're talking about, though, and you'll find we'll talk about this in kinesiology too, is if you use one type of goniometer for a specific joint, you want to stick with that goniometer for that patient. That allows things to be a little bit more consistent, right? We all have, and at least in the clinic, I know that I did, we all have our favorite goniometers we try to find when we're in the clinic. I keep my own goniometers in my bag so nobody touches them and nobody messes with my goniometers. That allows me to say, if I'm measuring somebody's shoulder flexion, I'm always measuring it with the same goniometer so I get consistent results. Your Therex book says avoid visual estimates, right? But a goniometer is more because a goniometer is more accurate and reliable. That's true. But we're going to learn in kines that even though you're going to avoid reporting on visual estimates, you're still going to give yourself a visual estimate, right? So you're going to actually move the patient through the motion and go, that looks like about X degrees. So that when you actually measure it, you can see how close to that guesstimate you've gotten. So what can affect flexibility? Well, stretching. The more you stretch, the more we tend to have a little bit more range of motion. I know this from experience at my hamstrings, right? I know that as soon as I start bending over to touch my toes, my knee starts flexing because it's going, I don't like this because my hamstrings are tight. Excuse me. So when we're talking about stretching principles, our goal itself is to increase flexibility as to increase range of motion. I'm sure if I asked most of you guys in this classroom, most of you will have at least one muscle that's probably tight on you that could use some stretching. If it's not the hamstrings, it's probably the upper traps, because I see some of you, and you got your shoulders all up there and you've got no neck, like that guy on what's that show on
Big Ed?
What's that?
Is it Big Ed? He's on
Big Ed. Yeah, there we go. That's his name. Is it from my 90 Day Fiance or whatever?
Yeah, 90 Day Fiance.
Right? Doesn't look like him, right? He definitely has some flexibility problems in those upper traps, and I'm not sure there is a neck under there. Right? He actually has a condition that causes that. We'll talk about that a little bit. Not in this lesson. We'll talk about it when we get to the neck. So the more flexible you are, that's going to lead to less stiffness. The best part about that is, and it's true, I know that when I was more flexible, when I was stretching more frequently in the martial arts, and when I was doing a little bit more stretching even at the gym, when I wake up in the morning, I could bounce out of bed a lot faster than I can now. Now, when Mr. McKeever wakes up in the morning, it's more like, Oh, okay. There's my back. Oh, okay. Yep. Hello, back. Oh, hello, neck. Oh, hello, traps. Yeah, you're there, right? Oh, hello, upper back. Again, I binged on that's fantastic. So the more flexible you get, the less you're like that every day. Now, when you first start stretching, have any of you ever done a full stretching program before where you just focus on stretching and increasing your range of motion? Maybe for gymnastics or for dance, anything like that? I said, Riley, I thought, good, yoga, right? There's a good one. What happened the first couple times you went to yoga? What did you feel like afterwards? I mean, initially after yoga, it probably felt pretty good. Yeah.
Yeah, you're in pain kind of.
You're like, oh my God, why did I do this? I remember I did for my PT program, we did a required day where we had to go out and do some sort of an exercise we don't normally do. And I'm like, I'm going to go do hot yoga. I don't know why I chose that. I hate heat and I'm not flexible. And, I was that person in there going, oh, what are we doing? This is ridiculous. And I'm like, when I was stretching, I'm like, this feels really great. And then I get out of there and I hit the cold air outside and I'm like, oh, everything just locked up on me and I could barely walk. The next day I get up and I'm like, I feel like I'm 90. So the more we stretch, that flexibility training decreases the stiffness and it will overall improve in time, right? So those of you that are going to yoga, has it gotten easier as you've gone along? I hear it has. I don't know myself personally because I'm never going back to yoga ever again. Yeah, right? I like that Anthony's like, yep. The same way, I'm right there with you, Anthony. I'm like, yep, once and done, I did it. I'm good. So overall, the other thing that's going to happen is your stress tolerance is going to improve. It's the same thing you guys are getting right now, right? How many of you guys hate Zoom lessons? Some of you are like, I like it because I don't ever have to get out of my pajamas. Brooke's like, I love them, right? So some of you hate them, right? With my entire soul. There are pros and cons, right? Anthony, pro, you don't have to get out of you don't have to leave your house. Con, you don't have to leave your house. But think about it. When we first started doing this, your tolerance level to those lessons was like here. Like, I hate this. It's like, I like saying the dogs. Overall, though, your tolerance level has gone up. And that's why in the first couple semesters, we didn't really have any 4-hour classes because your tolerance level for sitting for classes wasn't quite there. Yeah, I can get distracted. That's why I have to be in a room where I'm kind of closed off. That's why I like my office, right? Yeah, that's the other. I agree with you totally there. And I just filled up my truck for the first time in like a year, and I was very sad about that. It's like, oh, I have to actually fill my truck up. But then again, it's like 37 gallons, so it can get me a year if I don't drive much. So that means as you build up tolerance, your ability to do it's going to become more and more frequent, right? Now, can you get to that same level of soreness? Sure, right? If you push yourself really hard, even at yoga now, right? So say Anna's going to yoga and she's been going for a year. If she suddenly really increases her intensity in yoga, she can get back to that same level of soreness she had day one, right? If she really pushes herself. So you can get back there. So you're stretching to inhibit that reflex activity that will decrease your range of motion. So you're going to improve that true range of motion. I said already, warming up is great. With patients, typically we're going to do a passive warm-up. And a passive warm-up is one where they're not going to do anything. A lot of times that's a hot pack. It may be ultrasound. Anything that produces heat. It may be a diathermy machine, which honestly, I can't tell you the last time I actually saw a diathermy machine, other than there was one in a nursing home that I worked in a long time ago in a land far, far away. Do you guys remember learning about shortwave diathermy in modalities? Briefly, vaguely, right? It's the one that uses radio waves to create the heat. And there are these huge honking machines that have these big heads on them that you put over the patient. Basically, essentially what you're doing is putting them in a McDonald's fry warmer. That's really what you're doing with the patient. So warming up does prepare that tissue for the activity. So if that repairs your muscle tissue, do you think also warming up improves your neurofunction as well? So your nerves conduction?
Yeah.
Yeah. Right? There's only one area of the body where nerve conduction is improved with cooler temperatures. Does anyone know what part of the body improves with cooler temperatures?
Your brain.
Exactly. Yeah, your brain. Your brain works a little bit better in cooler temperatures because what happens if your room's nice and hot? I'm going to take a nap. I don't know. Well, to a point. If it gets really hot, then no, you're not taking a nap because then it's uncomfortable, at least, or at least for me. Some of you are like, nope, it can be really super warm and I'm happy. Can't do that. It's got to be somewhere between warm and cool for me. So as that range of motion is going to increase, as that warmed up tissue increases, right? The warmed up tissue can also contract more forcefully and relax more quickly, right? Whether from external or internal heat. Why? Well, because when you heat up things, it increases blood flow, it increases temperature, it increases the cardiac response. And the other thing is it increases the breakdown of that oxyhemoglobin, meaning the hemoglobin that brings your oxygen and exchanges for carbon dioxide and brings it out, it'll increase the breakdown in the exchange that goes on. Freezing 1 foot out. I love that. Freezing big blanket 1 foot out. I actually like that theory. That's actually, usually for me, it's my shoulders out though. I like my head and my shoulders up nice and cool, but the rest of my body can be warm.
Mr. McKeever, would you do like a warm-up activity more in a inpatient setting than outpatient setting?
Yep. So that's what I was going to mention that. Good lead in there, right? Well, it depends. So I'm going to say this. If you keep using a passive modality to warm up the patient is going to become addicted to those passive modalities. And sometimes you have a patient that comes in, no, man, I can't do therapy today, but you know what? We can just do the hot pack today. No, we can't do that. That's not therapy, right? And so overall, as the patient progresses in their therapy session, they should be moved from a passive warm-up to more active warm-up. And in the hospital setting, you're right. We usually do more of a active warm-up where they're getting up and moving more than just throwing a hot pack on them, especially because if they're in an acute setting where maybe they just had a surgery or something like that, we may not want to throw a hot pack on them and increase that inflammation and kick off like an inflammation cascade that's going to make things worse. So it's a fine line. Can we do a hot pack with somebody in the hospital? I mean, sure, under certain circumstances, but typically more just getting them up and walking is going to be a better idea. So great question. So when we're stretching, I told you before, we can do static or we can do dynamic stretching. Static stretching is what we most commonly think of when we do stretching, right? It's where we put a arm out in a long, elongated position, and we're going to hold that position. Passive stretching, right? So if passive is the term for stretching, that means the patient is not doing it. When you're doing that passive stretching, something externally is going to be doing the stretching, and it should be stretched slowly. Should not cause pain. And when I say, does that mean that, oh my God, when they get out here and like, oh, that's a little sore? No. When I say doesn't cause pain, I'm talking, ow! They shouldn't be screaming while you're stretching them. It's okay for them to be in a little bit of uncomfort or discomfort when you're doing stretching, but they shouldn't be in agony while you're stretching them, unless, of course, they're working with me, and then it happens all the time. So what are some advantages of doing static stretching? Well, it reduces the chance of exceeding the strain limits, meaning it's harder to get to the point of ripping a muscle if you're doing a static or just a prolonged, what we call low and slow stretch. It reduces energy requirements, right? So if I put my leg up here on the chair arm and I kind of lean into it, stretch my hamstring, there's not a lot of energy requirement there for me to do that. It's primarily just my body weight and relaxing and allowing it to happen. There is a reduced potential for muscle soreness, but DOMs can still kick in depending upon the person. So you want to pay attention and tell them drink a lot of water after it, stretch a little bit more after it. They're also very easy to teach. Low and slow stretching where you're kind of going, okay, so we're going to stretch the upper traps. You're going to hold that over there and hold that for a full 15 seconds. It's really easy to teach stretches like that. Teaching ballistic stretches can be a lot harder. So when we're doing static stretching, our goal should be to prevent or minimize the risk of soft tissue injury. We don't want to tear the muscles. We just want to stretch them. Even though in stretching, what we're doing is causing itsy bitsy micro tears in that muscle in order to allow that collagen to come in there and rebuild it and lengthen the muscle out. It's going to improve movement. It's going to improve flexibility, and it will prevent a contracture. That's the ultimate bad thing we're going to encounter in physical therapy, is where the muscle just says, yeah, you know what? I'm going to stay like this forever. So ballistic stretching or dynamic stretching. A little bit. Dynamic can be passive or it can be active as well, or it can actually be active assist as well, Brooke. So passive would be if you're my patient and I stretch you out. So I get you up on the mat and I'm stretching your hamstrings out. And we're going to do all of these. I think the second lab we do in Therax, where we're going to try a manual stretch passively by somebody else. We're going to try a manual stretch active assist, meaning you're going to do some of it, somebody else is going to do some of it. Then you're going to do it by yourself. And then we're going to do a ballistic stretch. And we're also going to do a Pnf stretch, which we'll talk about. And we'll compare and see which one makes us feel like we're less or more stretched out, I guess would be the better term. Ballistic stretching is typically less desirable in the inpatient world or in the hospital world or in the therapy world would be the better term. It places tissues at higher risk because of the jerking, bouncing movements, right? If I'm doing a ballistic stretch in my arm, I'm going to be bouncing. That's kind of what ballistic means. It's a bouncy stretch. It will stimulate the muscle spindles, and we're going to talk about the difference between muscle spindles and Golgi tendon organs in a few minutes here, which does increase or continuous resistance, which may stop it from stretching further. So why might we avoid or why might we do a ballistic stretch? Well, ballistic stretch is a really quick way to get a rapid change in length. So for example, maybe you're doing something where you're doing a competition. Sorry. And in that competition, part of it is measuring flexibility. Ballistic stretching or bouncing stretching really can get you to a greater range of motion faster, but you won't hold that as long. Whereas that low and slow stretching, it might take you longer to get there, but you'll hold your results longer. So going along with ballistic stretching or dynamic stretching is true dynamic stretching. It's where we're going to use a muscle contraction to stretch a muscle. So for example, if my problem is my hamstrings are too tight, I can actually contract my quads to force my knee down into extension in order to stretch out my hamstrings, right? So it's going to increase or decrease the joint angle where the muscle crosses, thereby elongating that muscle at the joint level. A lot of times these are going to be more on activities or specific or activity dependent movements that prepare the muscles for a particular sport. So maybe you're doing shot put. So you got to get a load up and you're going to be throwing the shot put. We may actually practice doing that shot put over and over and over again. And I'll answer your question in a second, John, where we're stretching that out as we do it so that once you get to throwing that shot put, you don't tear your muscle. John asked, do we ever do ballistic stretching for our patients or is it just for athletes? I don't do any ballistic stretching with my patients, mainly because, again, my patients are more neuro-based. I do more of the Pnf stretching, more than pretty much any of the stretches I do, even the low and slow stretches, because I combine a little bit of Pnf with low and slow. Excuse me. But our old program director, before Dr. O'Neill was here, she only did ballistic stretching with patients. And her main reason was, again, she was more athlete-based. But even in her non-athlete population, because she did so much ballistic stretching, she had developed the level of comfort with it that maybe other clinicians don't have. I definitely don't have a level of comfort with ballistic stretching because I found that every time I do that, the patient overdoes it and ends up tearing a muscle or causing more injury. But definitely with athletes, ballistic stretching can be really useful. So kind of the last stretch is Pnf stretching, right? Does anyone know what Pnf stands for other than a lot of words? So PNF is a big fancy one that stands for, get over here. Where is my mouse cursor? There it is. So PNF stands for proprioceptive neuromuscular facilitation. So breaking that down, proprioceptive, ability to feel their ability or where they are in space. Neuromuscular, dealing with the intersection of the neuro system and the muscular system. Facilitation, somebody providing them with a guide to move forward. So that's what PNF stands for. You don't have to know a ton about that yet. We're going to actually have 2 full classes on PNF, both stretching and range of motion and patterns. Some of you are like, well, I've heard of PNF, but it's kind of pattern-like. That's okay. We're going to talk about those patterns and how we can use those patterns to stretch. But PNF uses techniques that promote neuromuscular responses. It increases range of motion by decreasing resistance caused at the spinal nerve level, or that reflex pathway. We're going to use isometric and even some isotonic contractions to produce strength in diagonal or straight line patterns. And it's going to increase range of motion by stimulating those proprioceptors. So this is where we come into that Golgi tendon and the muscle spindles here. So I want to come over here and we're going to draw a muscle. Where is my cursor? There it is. So we're going to come over here and we're going to draw our muscle out here. So here's our muscle, right? At the end of each of the muscles, we have a tendon. Sometimes we have a tendon at both ends. In the middle here, in those muscles, is a muscle spindle. Right, so that's in the belly of the muscle. So the muscle's got the fibers that are going like this. In those fibers are a bunch of these things called muscle spindles. Out here in the tendon, there's a thing called a GTO, or a Golgi tendon organ. They have a very important job, but the muscle spindle and the GTO working together. So we're going to talk about muscle spindle first, and then we'll talk about GTO. The muscle spindle has a protection in it that, let's say I go over to the weight bench and I'm like, oh, you know what? It's already got 250 on it. I should be able to curl that. I can't curl 250, don't worry. But I go over and I grab that bar and I'm like, okay, I got this. And I start pulling up on that barbell and I actually start moving it. At some point, my muscle spindles, which are in my belly of my muscle, are going to say, if you keep pulling me, I'm going to tear. So the muscle spindles are going to say, nope. And what do you think it's going to make your arms do? Yeah, it's going to make them relax. Yeah, so now you're like, whoom, and you drop the weight. And you may have encountered this if you've worked to like 1 rep max or worked really hard and got up to that point where you hit true muscle failure, where you're doing curls, you're doing curls, you're doing curls, you're doing curls, and all of a sudden you get that one, okay, I got it. And the next one, you get a little bit, and then all of a sudden the muscle goes, nope, sauce, and drops the weight. Anyone ever hit that before? Okay, so John said, yeah, right? So that's because John's a beast. Kristen says, yeah. God, you guys are all beasts. So at some point, your muscle spindles will say, if you keep pulling on me, I'm going to tear. So what I'm going to do is force you to relax. And that's what's going to happen. You're pulling up. Those biceps are firing off. You're getting your guns going. And all of a sudden, muscle spindles say, nope, we can't do this anymore. And they relax your biceps. And everything happens involuntarily. It just drops it. So the muscle spindles, right? The muscle spindles help during contraction. I just spelled that totally wrong. Shh. There we go. So during contraction, they're going to protect your arm from lifting too much at one time. versus the Golgi tendon organs. The Golgi tendons are out at the end of the muscles, right? So they're the ones that attach onto the bone. The GTO's job are, if I stretch way far out and I get past the point where I normally can stretch, so I'm out here and I start leaning down, at some point, I'm going to hit a point where that tendon feels like it's pulling off the bone, like a rolled ankle, exactly. And what the GTO is going to say is, rather than the muscle spindle, which said relax, the GTO is going to say, if you pull me much further, I'm going to rip off this bone. So what I'm going to do is cause the muscle to contract. So in that case, if I'm stretching my biceps and I'm stretching, the GTO is eventually going to say, if you pull me any further, I'm going to rip off the bone. So what I'm going to do is instead is trigger the muscle to tighten. And it's going to cause a reverse action to get you out of the position you're in to stop you from actually tearing the bone, the tendon off the bone.
What does that feel like? Is it like a sharp cramp or something?
It can be, yeah, absolutely. If you've ever had one of those where you're like maybe stretching and all of a sudden the muscles start cramping up and pull you in, or like Brooke said, a rolled ankle, when you roll that ankle and all of a sudden the ankle kind of snaps back to neutral, that would be an excellent example of a GTO firing saying, you know, hey, you stretched me too far. If you keep going, I'm going to tear off bone. We can use these. I'm actually, when I demonstrate PNF, that's why it kind of ties in with PNF, I'm going to use techniques. So how many of you guys have thought of the GTO? Good. Awesome. See, it's starting to connect there, Brooke, a little bit, right? How many of you guys have seen somebody do PNF patterns before in the clinic? In clinic with shoulders, right? So there are a couple of different PNF patterns. We'll talk about them. But one of the ones I really enjoy doing is what's called D1. And D1, I like to think of as you're grabbing the apple, you're eating the apple, and then you're throwing the apple away. I can actually trigger a GTO reaction when I'm way out here in extension, that if I do what's called a quick stretch, they kind of cause a ballistic bounce out there. If I cause that bounce, the person's arm will automatically go back up and across for me because the muscle saying, ow, you stretched me really far. I need to protect myself, so I'm going to contract. And we'll do that. Somebody will, maybe Anthony will volunteer to be my patient for that when I demonstrate it, because he looks like he's having fun. He said he has seen it. So, you know, we maybe use him as an example. It looks really painful because what I'm literally going to do is I'm going to take his arm out to the side and I'm going to bounce it out there. And it's going to be this really rapid kind of pop motion. And even doing that with my arm alone, I kind of get a reverse muscle contraction going on where it's saying, hey, old man, you're tight. You're not, you know, you're no longer the age of some of the kids in this class right now. You've got to stop doing that or you're going to tear your bones apart. Does that make sense or help understand the muscle spindle versus the GTO? Okay, good. So muscle spindle in the muscle belly protects against too much contraction weight. GTO in the tendon, it says it in its word, right? Golgi tendon organ protects against excessive stretching. That clear? That's, I mean, I can't make it any harder, easier than that. And again, we'll get into the kind of the thought process behind that in those two whole classes with PNF. But at least if you get that basis down, that really kind of does help when we get to PNF talking about it. So what should we do when we're actually doing stretching? What should our duration? What should our intensity should be? How long should we stretch? How often should we stretch? Well, ideally, a static stretch should be hold at least for 15 seconds, if not for 30. And for about 3 to 5 reps. So let's say you wanted to increase your hamstring length on both legs. You want to do 3 to 5 reps, right? So 3 to 5 reps at about 15 to 30 seconds. Now, if you ever put that in your note that you give to me, I'm going to smack you. Because what I would expect you to see is, say, 3 reps of 15 seconds or 3 reps of 20 seconds. If I ever see 3 reps of about 15 to 30 seconds, I'm going to throw something at you. That's a no-no. Pick a time. How long is the patient going to do it for? Tell them. Okay, so we're going to do this stretch and we're going to hold it for 20 seconds and then count to them. Because there's something about hearing that countdown that allows them to know how long they have to hold that stretch for so they don't freak out while you're doing it. If the patient's stretching, they need to understand that they're not going to exceed their pain limits. So if it starts getting too painful for them, they need to let us know if we're doing the stretching. If they're doing the stretching, they have to know, look, if it starts getting really sore, you have to stop. Because at some point, you're going to get a diminishing return where you're actually injuring yourself more than helping yourself. It takes 6 weeks of solid, constant stretching to demonstrate significant increases in flexibility. Does anyone know how long it takes to undo that 6 weeks if you stop doing it?
Like a
Yeah, actually less, Joe, about a week. So think about that. So you put 6 weeks in to get there, and then you stop for about a week. You can lose most of your flexibility in 1 week. And some of you may have known that. Have you ever injured yourself and then you haven't gone to the gym for a week and then you go back to the gym and you're like, holy crap, this sucks. Your body deconditions faster than it conditions. That's why there is some benefit to, even if you're not feeling the best, right? Going at least and getting something done at the gym. If nothing else, get on the treadmill and walk for a little bit. You should stretch 3 times a week to improve flexibility. And then once you get to a point where you're happy with your flexibility, you want to stretch at least 1 time a week to maintain your flexibility. So 3 times to improve it, 1 time a week to maintain it. So what's going to happen if you actually do this, increased flexibility? Well, you're going to have obviously increased flexibility. You're going to have relief of muscle soreness, meaning that after you've worked out, you're going to recover a lot faster. Your muscles are going to relax quicker. I know for myself that if I have a constant regimen of stretching, I sleep better because my body is able to relax a little bit better when I get in bed. It also kind of ties into the fact that if I've worked out, I've worn myself out a little bit, so it's a little easier to go to bed. There's going to be performance enhancements that go along with it. Not only will you improve your overall stretching, but you'll also maybe do a little bit better at your running. It won't take you as long to go a mile. Maybe it took you, you had a 10-minute mile pace. And now because you're improving your stretching, now your mile pace is 9 minutes and 30 seconds. That's still an improvement. And that can be really big just by doing simple stretching. So what happens when we end up and we get into that contracture phase? Well, we've got to figure out how we're going to stretch that contracture out. So once we get to the point of the patient actually having a physical contracture, so at that point, it's no longer just a tight muscle, right? We all have tight muscles. Right now, if I take and I stretch my upper trap, oh, yeah, I can feel that really good, right? And I'm barely doing anything. That's just a tight muscle. A contracted muscle or a contracture, I'd be looking like this and not being able to move that head. You're like, come on, Mr. McKeever, let's stretch your neck out. And I'm like, I am stretching my neck out. See, I'm moving with it, right? So when you have that, it's going to involve the muscle, the capsule, so everything surrounding the joint, the tendons, the ligaments. It can lead, if you have burns, that can also come along with those skin contractures. And then also just skin in general. Your skin is going to shorten. If you spend a lot of time in this position here, eventually this skin will get used to being in this position and it will contract too.
Mr. McKeever,
Yes.
I had a question when you were talking about if somebody can't like hold a stretch and it starts to hurt, and for like soap notes when you said the 15 to 30 seconds. So would we just write, okay, no, this is what I'm trying to say. Okay, so if we were to stretch them and they're like, ow, 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 that hurts, do we pull off a little and keep the stretch or just completely stop and then write how far we got?
So I would put, so my thought process, at least in my standpoint, is if they're screaming, ow, that's too much. Yeah, we want to back off.
Okay.
Right. We have to learn our patients. I'm not mean to my patients right at like day one. If you are my patient, I'm not totally mean to you day one. I will get mean to you the more I learn you, because what I learn is this really, is this really her saying that she's in pain, or is it she just doesn't like the feeling and she's fighting me a little bit,
Okay.
So there's a delicate balance there. But yeah, so let's say we're stretching, we're doing hamstrings and we're doing 3 by 15 seconds, right? We can do a couple things. We can back off, and instead of doing 15 seconds, say, okay, I know it hurts, but how about instead of doing 15 seconds, let's hold it for 10.
And do we keep the same resistance on them?
At that point, we would keep the same resistance. If they say, no, it's too much resistance, then I'm going to keep that 3 for 15 seconds. I'm just going to back off my resistance.
Okay.
Right?
Yes.
The other thing is, does anyone know how we denote? So let's say we're doing, I want to write this a little better here. So let me clear it real quick. So let's say we do a long sitting hamstring stretch, and we'll talk about this one then. Long sitting hamstring stretch. And we did it passively. So I got to add that. So passively meaning that the therapist is doing it. Passive long sitting hamstring stretch, 3 by 15 seconds. The patient's able to tolerate, but still says they're in pain when we do it, but they're like, keep going, it's okay, I can handle it. How do we denote that with that exercise, the patient had pain? Does anybody know? Any guesses what we might put behind it? We can put a word. There's an easier way for it though, right? That's why I'm asking this. So what we can do is we can put an asterisk after it. So a star, that's an asterisk. That's not a TP that's falling over, right? So that star, right? The asterisk that we normally do, that looks a little bit better, a little bit. Now it just looks like a Blair Witch symbol. So if you put that star behind your exercise, that means the patient, or maybe if you have a an electronic health record and it just puts a 5-pointed star behind it, that's fine. What that's indicating is the patient was able to tolerate 3 for 15 seconds, but they had a lot of pain while they were doing it. That tells me next time I do it that, okay, so they were able to tolerate it, but they had some pain, so I got to pay attention to it. I'm not going to push it any further. If I don't see this, I may think, okay, the next time I do the stretch, I may try going a little bit further because there was no pain that was associated with it, because we want to keep pushing our patients a little bit further and a little bit further the more we go on. If they stay where they are, they're not going to improve. But that asterisk behind anything, let's say even with an exercise, so let's say we do bicep curls. And we do bicep curls with a 3-pound dumbbell. And they did 3 times 20 reps. And they said, when I was doing that, right, every time I did those reps, I was in a little bit of pain. It hurt, but I could tolerate it. I'm going to go behind this 3 by 20 reps and put an asterisk. And all that's going to indicate is it is standard for all clinics. Yes. Now, there are some clinics that will say with pain or without pain, you're just typing it out. But asterisk is pretty standard in most clinics I've encountered in the Valley. But if you put that asterisk behind the exercise, that means the patient had pain with the exercise or with the activity. I know that Health South was that way. I know that the 3 clinics I worked at were that way. I know some of the hospitals are way, but some of the hospitals also have a little click box that says with pain. So like there'll be a little checkbox over here that says, with pain. And then there'll be another checkbox that's like without pain. And you just check whichever one you happen to get in that electronic health record. So when we actually are dealing with a true contracture here, so now we're dealing with, again, not just a muscle soreness and not just a little bit of pain, but that muscle is now kind of starting to get replaced with some fibrous tissue. we not only have to stretch the muscle, but we also have to stretch the capsule around the joint. So everything that's holding the joint in place, all the tendons, ligaments, burns, and skin that go along with it, right? So long duration, low static load stretching is preferred for this, meaning they're going to have a longer, instead of it just being 15 seconds, it may be 45 seconds you're holding that stretch. But instead of, being at the point where you're just at that point where the muscle's fighting you, you're going to go to that tension point and just hold it at that tension point and do a very low load, very static hold and stretch. Let's say, yep, go ahead.
Sorry, Mr. McKeever. Is this always going to be like passive?
Yeah, this will typically always be passive. And I would even consider them holding a weight kind of a passive stretch because they're really not doing the work. The weight's doing the work, right?
Okay.
But let's say, Mr. McKeever goes out on his motorcycle on a Friday night and I get, a little bit excited. I'm riding around with some friends and I go out to Red Rock Canyon. And for whatever reason, I'm stupid and choose to go riding in a tank top and shorts. Don't ever do that. And I go around the corner and I lay my bike over and I slide along the pavement for 20 or 30 yards. When I do that, I'm going to have massive road rash on my skin. It's basically a road burn, right? That's going to lead to contractures of the skin, which will lead to contractures of the muscles underneath. So you have to make sure you understand how that skin is healing when you're stretching it, because if that skin doesn't heal properly, it's going to be replaced with low quality fibrous fibrous collagen that won't have that same flexibility as my normal skin. And then I'll be kind of stuck where I kind of get that shoulder rolled forward because the skin is what's restricting me more than the muscles underneath. So you have to watch scar tissue when you're working. You can also develop scar tissue in the actual muscles themselves. It can be from adhesions, meaning those little trigger points that we found, well, now they become really kind of bound down or holding down maybe the fascial layer, which is that layer between the skin and the bone or the muscle, and that's binding down to the muscle. Or maybe the fascial layer between the fascia and the skin is binding down. So we may have to relieve that first or work on that scar adhesion process before we work on the muscle. An immature scar, meaning a scar that's saying bad words, right? That's what an immature scar is, right? How do you know if a patient has immature scar? You take the bandage off and it's like, you're a jerk. That's an immature scar. No, I'm just joking. No laughter. Okay, I got it. Thank you, Danielle. It made me feel better. Thank you, Bianca. And thank you, Oscar. You gave me a little bit of humor. At least I give you a little bit of humor. Right? Immature scar is one that's 8 weeks or younger, right? So maybe you've got a patient at total knee replacement. From the day that surgery happens till about 8 weeks, we'll consider that scar immature. And what that means is that scar hasn't fully healed yet. As you go from the 8 weeks and hit up to the 14 weeks, now it's going to become less and less changeable. It's going to become more and more mature. So if you look at this, obviously a scar matures a lot faster than a man ever matures. Would you agree with that, lady? Look at this. It matures in 14 weeks.
Yes.
Okay. Okay, so at least I made some of you laugh. I appreciate that, right? So, some of us still are late in our years. I just won't say when, but late in our years, and we still have it. Quick answer that John's like, go ahead and ask your significant other about that, John, and see if you don't get a quick answer. I'm just saying. So a mature scar starts forming at about 14 weeks. Well, it starts forming at about 8 weeks, but it's really formed at 14 weeks. That means any change we make to this scar has to be done before that 14-week point. And when you figure that out, I usually say at 3 months, what we have in the scar is what we're going to get. So again, I don't know, maybe if I get up a little closer here. Can you guys see my scar on my neck there? We'll talk more about that when we get to class, but my scar started forming and actually matured a little bit faster than it should have because it closed off and then it reopened. And it didn't heal very well. And so I've got a pretty nasty, it's mostly bad tissue scar there. It doesn't look very healthy. Well, it's healthy skin, but it doesn't look as good as the skin around it. Some of you may have scars like that. Maybe you've got an area where you've stepped on a nail or you cut yourself and it's just not healing properly, right? Keloid scarring. Yeah, this isn't a true keloid yet, but keloid is where it's really bad, right, Stephanie? That's where at that point, that scar is just kind of nasty and had almost no tensile strength. The tissue that I have on my back of my neck is almost more keloid than the front of my neck. It's more of kind of a fibrous, blocky tissue versus the nice, soft, supple skin. My neck skin is no longer supple. It also makes it very difficult to shave, right? And there are no hair follicles in it. Daniela says, I got a keloid scar, okay? Yeah, right. These things happen, right? Sometimes mamas, when you have to have mature scars and fuss. I like it. That's actually, I'm going to have to save that one. Thank you. I will save that one. When you think about it, when somebody has a C-section, that's cutting through a lot of tissue on the belly. And a lot of times they're going to end up with a bad scar. And we really have to kind of take care of those scars so that the scar doesn't become a nasty kind of looking, not healthy looking scar. But once you hit that 14 weeks, you can't change it. So right now where I'm at, because I'm many years out from my surgery, this scar is what I have. It just is what it is. So how do we do this? Well, we're going to mobilize scars. We're going to talk about different types of tissue. We can do cross friction massage. We can do lengthwise, moving longitudinally with the scar. There's all kinds of massage we can do with it to keep that scar mobile, agile, and hostile so that it grows back a little healthier. Immature scar models immature scar tissue can remodel, meaning that if it's young, we can still change it and make it a healthier scar than if it's not. But if we don't pay attention to it early on, we can end up with a really kind of nasty looking scar. So we got to pay attention. So under 3 months, we want to be working that scar.
Are we going to be doing a lot of like wound care as well? Like in terms of that?
Wound care, keeping it as my favorite word in wound care. We're going to keep it moist because a moist wound heals nicely, right? And it lays down nice tissue. Some of you will get eked out every time I say moist in wound care because it's such a weird word. We want it to be nice and moist, right? Everyone likes their bread nice and moist. It can. There's a balance. There's a very delicate balance there, Brooke. Right? So Brooke says, I thought it makes it too soft. Yeah, like on feet. Exactly, right? So if your feet get too moist, they start breaking down. They start macerating, right? Or like say you go out to a hot tub today and you spend 6 hours in the hot tub and you get out, what's your skin look like? You look like an old person, right? You're all wrinkly and crinkly. That's maceration. That's when the skin starts softening up. Now, for most of you because you're younger, that maceration doesn't affect you. And a little bit later, you look and your skin's right back to normal. You're like a raisin, exactly. But for an older folk, maybe somebody 65 or older, they get that maceration. It makes that tissue nice and soft and really easy to tear. So maybe they get out of that hot tub and then they go sit on a bench. And as they sit down, they don't realize it, but they tear part of their bottom. We actually had a guy once who was, I want to say he was like in his 80s at the hospital. He got in a hot tub. It was back in Pennsylvania. He got in a hot tub, spent about 2 hours in a hot tub. Because he's like, oh, it just felt so good. My muscles felt so good. I didn't want to get out. And he got out of the hot tub and then he sat down to dry off and stuff like that. And when he sat down, he ripped a 2-inch tear in his rectum. Right? Yeah, Stephanie's like, yikes, exactly. He's like, I didn't think something would happen. But he did it. He did the typical kid thing. He flopped down on the bench. And when he flopped down the bench, it was enough shear force to tear about a 2-inch tear in his rectum. And so he had to come see us in wound care to get that taken care of because, well, it wasn't healing. And why it wasn't healing? Well, he had all other kinds of other comorbidities too. He had diabetes and everything else, right? So as that scar tissue forms, right, at first, the collagen fibers are highly unorganized and arranged randomly. So let's say we first get that cut, like I get this first cut in my neck. When that collagen first comes in, the only thing the collagen wants to do is fill in that scar or that hole. So its job is just to make sure it's full. As that scar tissue gets better and better, you want to try to get it so that it kind of lays on top of each other, runs in line with the rest of the skin, and forms a nice kind of springy barrier to anything underneath so that it becomes more organized. So how can we do that? Well, we can work on stuff like friction massage. Also, nothing against, but even just getting up and moving. So you have a total knee replacement that has that zipper scar down the front of their knee. Just getting up and moving can help mature that scar and get the collagen laying the right direction down that scar so the knee doesn't bind up. So we know specifically, critically component-wise, scars have a time-dependent, stress-reactive nature, meaning the more we work on them, the earlier we work on them, the better they are to develop into a normal scar. That being said, there is fragility in the early phases. So when you first get a scar, you first get an injury, you don't want to mobilize it right away. You've got to get some nice tissue laying down and you start seeing that collagen fill in, then we can start working on it. So if I have a patient maybe that had a total knee replacement and that what I call the zipper scar, which is a scar that goes the whole way down the knee, right? That zipper scar doesn't heal and it just stays open. I'm not going to work any scar work on that until I've got a nice kind of shiny layer of skin laying in that scar that I can start mobilizing. As that new scar tissue lays down and starts organizing it, as long as you're stressing it, right? So meaning placing some stress on it, making it do some normal things, stretching it, getting range of motion, getting them up and moving, the tissue will align itself and go right in line, right? So if we have that knee, I'm just using my elbow as my knee because it makes it easier. Or if I have an elbow scar here, right? I kind of want that tissue to go in line with all my other skin here. So when I extend my elbow or I flex my elbow, it doesn't hold me up. If the tissue's kind of laying just haphazardly in a giant pile in there, maybe when I flex my elbow, I lose range of motion. So again, low load, long duration stretching, especially combined with a little bit of preheating, can help tissues kind of lay down nice and neat for the scar. We have to be careful though, because if we're in that really early phase of scar tissue development, they may still be in that early bleeding phase. And what happens if we heat up tissue that is likely to bleed? Is the bleeding going to get worse?
Yes.
Yeah, more blood, right? Because heating vasodilates the area and brings more blood to the area. So bleeding is going to get a lot worse. We have vasodilation. Good. See, you guys learned stuff. So maybe in the early phases, we might use a little bit of cold. So we kind of constrict those tissues off so we can reduce the bleeding while we're doing a little bit of work. But scar tissue is really important to mobilize. And some of you, I know, some of you is going to say, well, what about cocoa butter, Mr. McKeever? What about this? What about that? What about, I don't know, Dr. Ho's magical scar tissue cream? Vitamin E oil, there's a good one, right? Why do you think all of those actually provide some benefit to scar tissue? There's actually some benefit to it. It softens it. How's it softening it? Exactly. It's lubricating it. It's keeping it, what's my magical word again?
Moist.
Moist. There we go. I'm getting y'all to say it. I love it. It's keeping that tissue nice and moist. And again, the more moist it is, the more it's able to move a little bit, which means the more, right? So if my tissue kind of is laying down like this and I keep moving it, as I keep moving it, it's going to get in line better, right? And then as it gets in line better, now that strength is there and it can flex a lot better, right? So if I put my fingers like this and I try to bend my fingers, well, I'm just, yeah, good. I'm going to skip over that, John, but good comment. I am not getting in trouble today with them. Right? So if my fingers are more in line, I'm able to flex a lot better here. But if they're kind of wonky and all over the place, it's a lot harder for me to bend this way. So we want that tissue to lay nice in alignment, right? It's just like the old thing, right? Here is the church, here is the steeple, open the doors and see all the people. We want that tissue to lay nice and neat in alignment. So we're going to finish this slide here, then we'll take a quick break because I think you guys need a little bit of a break. So when we're doing, yes,
Sorry, I have a question on that one.
I love it. Whatever you.
Do we just kind of base it off of like that 8 to 14 weeks when we do cold and heat or heat?
Yeah. So I usually don't start heat until about the 8-week point, but some clinicians say it's okay to start at like 5 to 6 weeks. I just have this problem, especially because I've dealt with a lot of patients that aren't healing right. So I deal with a lot more patients that have, especially in wound care, that have diabetes, that have, blood clotting disorders, or maybe you're on, anticoagulants, stuff like that. So I tend to wait on heat until about 8 weeks till I know that scar tissue is truly starting to get to that mature phase. But yeah, if you're looking, maybe you're at 4 weeks and you're looking at that scar tissue and you're like, man, it's nice and shiny. I don't see any blood underneath it. There's not any localized edema. I want to start adding some heat to kind of lay that tissue down. Go for it. Right. So there is a little bit of a clinical judgment that goes along with it. Mm-hmm. And for some of you guys, like I know, especially for those of you that I think there's 2 of you going out to Prump this first clinical, you guys will see wound care out in Prump, because out in Prump, there's only 2 clinics, and that means you've got to do a little bit of everything. So you'll see wound care, you'll see peds, you'll see adults, you'll see everything, right? Some of you that go into the hospital will see wound care. Some of you won't, because some of the hospitals like Sunrise, the nursing does wound care. That's okay. That doesn't mean you can't look at the wounds and go, oh, I see what, you'll see. And you've all seen that in your own injuries when you've gotten a cut or something like that, where that tissue kind of starts turning shiny. That's when that collagen is starting to mature. And at that point, yeah, then go ahead, add some heat to it. But you got to be careful, right? Because if I've still got localized swelling, say it's shiny, but my elbow's still swollen, I add heat to that, what's that going to do to the swelling?
Make it worse.
Make it worse. So you got to balance it a little bit.
So would you ask your PT to do that? Like,
yep, I absolutely would.
Before doing it? Oh, okay.
I would say, let's say that, I don't know, let's pick somebody here. We're going to pick, so Riley's my PT. I'd come to Riley and say, hey, I've been working with Jamie for the past 3 weeks. I noticed that scar tissue starting to look pretty good, but there's still some localized swelling. What do you think? Should I hold off on heat for about another week and get some input? Right? And maybe, all right. She says, yeah. No, yes, says Dr. Jenks. Great. So we'll wait for a couple weeks and come back and we'll maybe revisit in a week and say, oh, look, swelling's down now. Let's hit that heat. So maybe I'll add ice at that point. And maybe I'm not treating so much the scar tissue at that point. I'm more treating the localized swelling so I can start treating the scar tissue. So there is some balance that goes along with it. Yeah, no problem. All right, these words keep coming back. Range of motion. Oh boy, right? It's a basic technique used for examination of movement and initiating movement, right? We have range of motion. All of our muscles have what's called a functional excursion. The functional excursion is how far that muscle can stretch, where the resting length is, and how far it can shrink or contract. So a true functional excursion is how far can it contract to how far it can go out. That's a true functional excursion. What's my muscle length like? Active insufficiency. What was that again? The muscle can't do what anymore? Contract anymore. Good. So if a muscle can't contract anymore as active insufficiency, that means passive insufficiency, it can't do what anymore?
Stretch.
Stretch. Good. See, look at, remember last semester you had some problem with that? Now it's starting to sink in, right? It's almost like I keep beating this into your head because it's an important concept, right? So when we do passive, we are going to do most of the motion, right? Typically the therapist, or it may be a mechanical force, such as in the case of like a continuous passive motion machine, which we'll talk about, or it could be someone else, could be family doing the passive range of motion. In the hospital, you'll find really fast that insurances don't pay for passive range of motion. because they'll say passive range of motion doesn't improve the patient. It just keeps them where they are because we're not going to go anything. So when you do passive range of motion, you are going to go to the point where you feel tissue tightness. Could be, yeah, absolutely. Great point, Anthony. So Anthony asked if gravity would be considered passive range. Absolutely. Gravity could be, for sure. But with passive range of motion, you're going to the end where you start feeling resistance, stopping, and then going back. So let's say I'm moving into shoulder flexion, and I'm limited to 90 degrees because at here, I start getting some tightness. If you were doing true passive range of motion with me and not stretching, just passive range, you're going to bring me to that 90 and come back. You're going to bring me to 90 and come back. And you're going to do that 20 to 30 times, depending upon what your orders are. When you're dealing with passive range of motion, and again, remember that passive range of motion is not stretching, because some PTs get that confused, and I can't find my mouse. I lost.
You said it's not stretching?
It is not stretching. Passive range goes from beginning point to tightness point. Or if you have somebody that's maybe tight, even going back, so maybe I've lost some extension and I've lost some flexion. I'm just going to go between those two tight points. So I'm not going to go into them. So let's say I was stuck at 90 and if I go in to go about 95, I can get some stretch with you. At that point, you're now doing stretching. You're not doing passive range of motion. Does that make sense?
Yeah, it does. Thank you.
So now, could I say, I'm going to do some passive range of motion on the shoulder along with a 5-second end range stretch? Sure. You just have to specify that very specifically, saying, okay, 3 times 20 passive with 5-second end range stretch with every rep. You can't just say 3 by 30 range of motion because that doesn't explain you to stretch along with it. Actives where we want to get patients to. Actives where they're doing all the work. So they're contracting and moving in that range of motion. And obviously active assist is where we start using things to help us, right? So let's see here. So I'm going to maybe I've lost some fingers. So I've got my finger, it's contracted here, and I'm stuck in this point here. Maybe I'll use like this, this is a glasses cloth, and I'm going to use that to help me come. That was good. Shot it halfway across the room. Maybe I'm going to use that to help me get back there. So I'm using a device to help me get a little bit of motion. So I'm contracting a little bit back, but I'm also using something else. Or maybe I use my own finger. And so I'm contracting back, but I'm also helping it. That would be an active assist motion. But remember, when we are doing range of motion, we're not going to stretch. Stretch is something totally different. So when we're doing active, we're going to the end point and stopping. So let's say I'm going to do one more example here before we take a quick break. Let's say here's my arm, right? So here's my arm, elbow, hand. I got 1, 2, 3, 4, 5 fingers. And here's my shoulder. Here's my elbow. And when I'm doing elbow range of motion, I'm limited to right there. So I'm limited to maybe, 100 degrees range of motion. Passive range of motion or active range of motion is just going to it and stopping. A stretch would be when I hit that 100 degrees and I go to maybe 110. And then I'm going to hold it out here. And I'm going to increase that range of motion. I'm going to say, okay, we're going to push into it. Okay, good. We're going to hold that. 5, 4, 3, 2, 1. That's true stretching versus range of motion, which is just from endpoint to endpoint. And that's important to understand. A lot of PTs even sometimes get confused with that. And they'll say, oh, well, we're going to add a stretch to it. Well, if we're adding a stretch, we're not doing passive range of motion. Stretching is stretching. Range of motion is range of motion. And again, like I said, in the inpatient world, a lot of inpatient medical insurance like Medicare, Medicaid, stuff like that, will not pay for passive range of motion because what they'll say is Passive range of motion isn't skilled because Jason could teach that to a family member to do. And if a family member could do it, that's not a skilled therapy, right? But stretching is a skilled therapy because we could teach a family member to do it, but could they overstretch a patient really easy? Yeah, right? Think about it. Would you want like your mom stretching you out or your dad stretching you out after having a bad day? Probably not, right?
No.
Exactly. You're like, no, I'm okay. I'll time out on that one, right? So that's considered a skilled therapy. We're also going to talk about when we get to PNF, there's a specific form of PNF called rhythmic initiation. Rhythmic meaning a rhythm, and initiation meaning starting. So starting rhythm, which is basically passive range of motion. But because we call it a fancy term, insurances reimburse us for it. Right, it's fancy, right? And because it's fancy, we get reimbursed for it. So maybe I see a patient, maybe I've got a patient that is in a coma. And we're not going to get any active range of motion out of a coma patient. We're just not. And if you do, they're not in a coma. But I can do PNF on them and still get units out of them while teaching their family some passive range of motion, maybe to keep their hands stretched and to keep their elbows stretched, where they're keeping that range of motion. Again, when I say keeping them stretched, I mean keeping the range of motion, not stretching them actively. They're keeping what they got so they don't lose it. All right, we're going to pause. Yep, go ahead.
And you would do this like at the beginning of the treatment, right?
Typically, yep. Yeah, usually what you'll find with me, or at least for myself, I typically do my passive range of motion first, or any type of range of motion activities first. And then I do a little bit of stretching and maybe some more range of motion activities, then their exercises, and then their cool down activity, maybe sitting on ice or maybe a little bit of stretching while they're on ice, right?
And then will the stretching be like when you're documenting it, would it be like under assessment?
Yep, could be. Well, so it depends. So we're actually going to talk a little bit about the noting for that towards the end. So if you hold that question towards the end of the lesson, because we're going to talk about how to document all this.
Okay, perfect. Thank you.
Yep.
Sorry.
Yeah, no, that's excellent. You're thinking ahead. I like it. Are there any questions right now? Because I think we probably should get up and stretch a little bit and move a little bit because I see Jason's nodding off on me a little bit there. I'm just joking, Jason. I know you're not. But I think getting up and stretching would be a little bit good. What do you think? So I'm going to pause the recording. So we're back from break, and the last thing we had stopped talking about was range of motion. I know I got really close to the camera there, but I wanted to sit on my foot. And active range of motion versus active assist versus passive. One thing I thought of while I was away is just remember, again, if your clinic now, so say you're on a clinic rotation and your clinic says, well, in our clinic, when we do passive range of motion, we push into the tissue and do stretching. That's not when you go, well, Mr. McKeever says passive range of motion doesn't have a stretching component. Passive range of motion stops at the end range of motion, and that's where it ends, right? Understand that some clinics do have kind of their own rules, but when it comes to the boards, so when it comes to your licensing, when it comes to everything like that, passive range of motion ends from one end to the other of resistance, and it does not go into resistance. So it, if I'm limited to maybe only 45 degrees of shoulder motion, that's the passive range of motion you're going to do. You're only going to do 45 degrees over and over and over again until you're done with it. So there's no tissue resistance involved in it. But if your clinic does it, I'm going to tell you flat out what your clinic does. Just get through your clinicals and remember that not all of it matches up to your boards. I'll joke very heavily with you guys once you're done with your third clinical that you need to forget everything you learned in your clinical and just remember the book stuff just to get through your test. Because we learn shortcuts in the clinic that we don't always learn, when we're learning the stuff in the book. So be aware of that. So why do we do range of motion? Or what would be an indication for range of motion? Well, passively. I like to think of when we're going through this, and remember, we're going to talk about patients that have injuries, right? What type of a patient do you think you're going to do passive range of motion with? How far along in their injury? Yeah.
Like early
Early
3 to
on.
4 weeks?
Yeah.
Acute.
So what's that period called? The what phase of injury?
Acute.
Acute.
If-
Yeah, so the acute and then into that subacute phase, right? So where you're starting to get out of that, so subacute. So when a patient's like, oh, I have an acute injury, it's so cute, right? So in that acute phase is when you're going to kind of stay in this passive range of motion. So when you first get injured, so let's say, you know, today Oscar goes out and he's shooting some hoops and he rolls his ankle. And he rolls it really bad, not just a little bit of a roll, but one of those rolls where he knows he's got to stay off of it for a while. I'm sorry, Oscar, you just rolled your ankle. That's just the way it is because you're the last of the type, so you get the injury. Rolls it really bad. He's not going to want to actively start moving it because if he actively starts moving it, he's going to increase the inflammation in that joint. And that's actually going to make it worse. Right. So we've learned through modalities that during that phase, he's going to use that 4-letter word. What's that 4-letter word? Actually 5, the new one, but what's the 4-letter word he's going to follow?
Rice.
Rice, right? And I like to, I know rice is the word we think about. I like to think of price better. Does anyone with the P adds into it?
Piece pressure, right?
Actually, it's protection. Pressure goes along with compression, right? So protection, right? Rest, ice, compression, and elevation. Protection meaning we're going to keep it safe, right? We're going to be like Frodo from Lord of the Rings. We're going to keep it safe and keep it secret. We're protecting that new injury so that it doesn't get worse, right? So Oscar's going to stop playing basketball for a little while so he doesn't re-injure the ankle. You know, if Oscar puts an ankle brace on and goes right back out to playing basketball, he's probably going to re-hurt the ankle, even if he has that brace on. So he needs to protect it, needs to come off of it, right? So that's where we're going to do passive range in that acute phase. So we're going to do a little bit of, we may even teach him, okay, so we're going to actually, you're going to work it into inversion and eversion, and you're just going to roll it back and forth with your hands. You're not going to actively move anything in the foot, and just kind of work it a little bit so that you keep his range of motion. Because again, that acute phase, the subacute can last, you know, we usually say about, 8 days or 8 to 12 days is a true acute phase, but that subacute phase can last for about 2 to 3 weeks. And if he does nothing in that 2 to 3 week period, he's going to lose a ton of range of motion. So if we at least do passive range of motion, we can actually at least keep what he has and not lose as much. So if the goals for passive range of motion is to not lose range of motion, right? So our goals here is 0 loss. That should be our goal, right? So with passive range of motion, and a lot of the books will argue on this, but if you talk to most clinicians, they'll say passive doesn't ever increase range of motion. It will increase blood flow, it'll increase tolerance to pain, but it's not going to necessarily increase your range of motion because you're only going from one end to the other. You're not actually going into that stretch, right? So we want to keep him from losing that range of motion. What else might we use passive range of motion for? Reduction of pain. He just really hurt that ankle, right? Passive range of motion is a really kind of gentle way of moving that joint around and getting it used to moving again, so it decreases his pain, or conversely, increases his pain threshold, where it becomes harder for him to have that really, really sharp acute pain right after injury. So we get there, right? And then we start getting that subacute phase. We maybe start transitioning to that active assist, start allowing the foot to move a little bit with it. And then once we get out of that subacute phase, so we're now beyond it, right? And whether we're getting into a chronic phase, that's acute, right? Or we're just getting into a return to function phase. So this could be going to chronic, meaning it's going to be a chronic injury for Oscar, or maybe he's getting to the return to function phase, RTF phase. That's where we're going to start getting into doing active motion. So we're going to start with just him literally moving the ankle, right? Back and forth, back and forth. And then we're going to start maybe doing some activity where he's on the ankle, doing some motion, walking maybe a little bit, sidestepping a little bit, going up and down stairs. And then again, Oscar's getting ready to go out and play in the NBA. So we got to get him back to sports. So we're going to start going from that kind of just moving it back and forth himself to doing some activities where he's going up and down stairs and walking to actually getting to some cut drills and doing stuff on a basketball court that he would normally do. So when we get in here, our indications for active range of motion is to improve it, right? Improve his range of motion. And again, return to function. So let's go actually going over here, right? Get him back to normal function. That ties to our indications. That also ties to our goals. So all our goals are going to be based upon that. For the patient to start with us directing him to becoming independent, right, in doing his activities. Does anyone know what the abbreviation for independent is on SOAP notes? IE is initial eval. Close though. Part of it's right. So independent is I with the circle around it. Right? That means patient's independent. At that point, if you ever put that on a note, say you say patient is doing, I don't know, ankle pumps, three times 30, and he's doing them independently. If he's independent, is he getting any benefit from us?
No.
No, right? So once an activity is independent, that should become either a home exercise program or should be pulled off of his exercise program entirely if he's in the clinic, right? Independent exercises they can do on their own. They don't need us. That's no longer skilled, right? We should be in there helping him, or we should be at least having him use devices to be modified independent, or at least a min assist with them, right? When you're doing independently, and this is one of the things I actually a few semesters ago, I was helping with I wasn't even helping with Dr. Reskin. I was out doing attestations, which is where we go out and figure out if graduated students are employed. And I go to see one of the clinics, and one of our students is there working with patients, is on a clinical rotation. And she's sitting there typing at a computer. And I said, "Oh, don't you have a patient right now?" And she's like, "Oh, no. Do you see that guy over there on the medicine ball? That's my patient. He's independent with all his activities. So he's doing all of his exercises on his own." Mr. McKeever's head just about exploded and spun around in 360 circle. Because if the patient's doing all of his exercises on his own, he doesn't need us, right? And that's old school PT. That's where we used to do that all the time. And that's why a lot of PT, like insurances, have stopped reimbursing us for some of that stuff. Because when they can do it on their own, they don't need us. There should be a challenge involved. We should have balance activities at that point or something to that effect. They should have activities that they definitely need us there. And again, like I said, this down here is what I talked about with getting him back to sports, right? Getting him through functional patterns, maybe doing some ADLs, some IADLs. Well, that's interesting. Have you guys learned the difference between an ADL and an IADL?
IADL is independent activities of daily living.
Yeah, or instrumental is the other term for it, right? So an ADL is stuff we need to function. We need to do, or we should be doing every day. Like what would be an example of an ADL that we should be doing at least almost every day? Showering.
Getting dressed.
What'd you say?
Getting dressed.
Getting dressed. There we go. Right. Again, I'm going to say this almost every day, right? Now, some of you may only, Anthony says brushing your teeth. That's an example. Some of you may only brush your teeth once a week, but at least you're doing it once a week. I'm just joking. None of you do that. I hope. Right. Some of you may only shower once a week. No, I hope not. Or maybe you only get dressed once a week. I don't know. I'm not judging. I'm just saying. Right. But yeah, those are our kind of ADLs. Those are the stuff we do every day, right? Eating. If we don't eat, we've got a problem, right? That would be another ADL. So then what is an example of an IADL? Something that we don't need to function, but we still do on our own.
Like writing a check?
There you go, writing a check, managing bills, good. Driving is an IADL, good job, John. And if we drive, we may go to the grocery store. Okay, Bianca says cooking, she took my next step, right? We go to the grocery store to buy some food, and then we bring that food home and we cook. All of those are IADLs, right? So those take the ADLs, the basic activities we do, and add a little bit onto it. But we don't need those to fully function, right? Because, John, could we survive without being able to drive? Yeah, right? And same thing, Bianca, we could survive without cooking, right? Especially in our age with Uber Eats and everything at this point. But it's still important. Postmates, exactly. We could survive on that. Or my sister is, she orders all of her, like the, what are those, like the Freshlies and stuff like that, those type of foods that she just can pop in her microwave and has an instant meal. But our IADLs are kind of the stuff that don't allow us to function every day, but are still important to life, right? Technically, going to physical therapy and going to occupational therapy would technically be an IADL, wouldn't it? And we don't need it to function necessarily, but it does make our life easier. I can either stand for independent or instrumental, depending upon the book you're reading. I prefer instrumental, and I think most of your tests will call it instrumental activities of daily living. That's fine, man. Don't you worry about ever asking a question. My instructor in the martial arts always taught me the only stupid question you can ever ask is the one you don't ask. Right? Because usually if you have that question, so here's the deal, man. If you had a question of what that I stood for, someone else in the class had that question but was too afraid to ask, so you just saved them asking. So we get them and we start doing stuff that they do every day, right? So again, I'm going to use Oscar here. So Oscar, really messed up his ankle. And so he's having a lot of trouble getting in and out of the shower. See, Danielle had it, right? He's having a lot of trouble getting in and out of the shower. So we may help him, teach him how to maybe get in and out of the shower. Or we may have to make modifications. Maybe he injured his ankle so bad, it's never going to fully heal. And so instead of having a step in, a step over tub, we may have to switch him to kind of a step in shower. We may have to make some modifications to his shower, right? I know, Oscar, you're getting the brunt of it now because you were the last one to respond. Sorry, man, it's the way it works sometimes. But the other thing it does is, and again, IADLs, maybe again, he's, like I said, he's training for the NBA. Well, training for the NBA would be an example of an IADL, right? And so the more we get him doing stuff like that, the more he's like, oh, now I understand why we did all this basic stuff in the beginning, because it's getting me back to where I want to be. So I can become a millionaire and not have to worry about my IADLs because I can pay people to deal with them. I don't have to manage my bills. I can pay an accountant. I don't have to get my food. I can have somebody get me my food, that type of thing. Just remember, Oscar, when you become an NBA superstar, don't forget all of us little people. That's all I'm saying. I'm good for like $500,000.
So when you do like, for example, like sports specific training, or those are going to be considered IADLs as well?
They could be. We usually consider them functional patterns, right? Or functional activities, but they're really, they really are IADLs. If it's something that a patient does on a daily basis that is not a kind of life critical skill, then yeah, it's technically an IADL, technically.
Okay, thank you.
Yeah. But let's change it. We go away from Oscar. Now we've got Millie. And Millie was at home one day, and she does a lot of knitting. She likes to make scarves and stuff for all the community kids, and she lives in Chicago, and it gets cold over winter. But the one day Millie got up, and when she got up, she fell forward and got a foosh, fall and outstretched hands, right? So now Millie can't knit. And we start doing the passive range of motion with her, get her through passive, we get her through active assist, we start getting her active. And then we get down in here, we're starting to teach her how to do her normal activities again. We're starting to maybe integrate some knitting into her therapy. What happens is all of a sudden Millie goes, oh, this is why I've been through this 4 weeks of torture, is so that now I can do what I've always wanted to do. And once they get to that point where they're starting to see how their therapy plays into getting to do stuff, all of a sudden you get a different buy-in. right? Especially, you know, if you're dealing with athletes. When you're dealing with athletes and you're doing all the boring stuff, man, they just are like, really, can we just stop this crap? I don't need to know how to get up from a chair. And you're like, well, right now, yeah, you do. Right? Because if you can't get up from a chair, you can't go play basketball. So yeah, there is a part of it that's developing that motor pattern with the patient. So I mentioned continuous passive motion, right? So continuous passive motion is passive motion performed by a mechanical device that moves a joint slowly and continuously through a preset controlled range of motion. Does anyone know what joint? That's why it's so important to find out their goals. You're exactly right, Sean. Thank you for adding that in there, right? And it's also not important to not only to find out about their goals, but also to integrate their goals into your goals, right? So have the we don't make the goals, right? But just integrate as a PT. When I say their goals into our goals, I'm talking from the PT standpoint, meaning the whole crew. The more we can integrate what they want to do into what we're making them do, the better off we're going to be. Has anyone seen a CPM before? Have any of you ever been in a hospital, hip CPM? Okay, good. Yep, that's kind of a rare one. I haven't seen one of those in a while. The main ones I see are knees. Or as I like to say, the knee CPMs, the knees. So I'm going to clue you in on a little secret here, and I'm going to post an article for you guys to read about CPMs. Here's the interesting thing. So the benefits that CPMs say they provide. They prevent development of adhesions, contractures. I'll give them the adhesions part. Stimulates healing of tendons, ligaments, maybe. Enhanced healing of incisions, maybe. Increases synovial fluid lubrication. Okay, I'll give you that because any movement does that. Prevents degradation of the effects of immobilization. I will give you that. The next one, quicker return to range of motion. Oh, maybe. And then decreases postoperative pain. Well, interestingly, what we found, and what I found here is, there's research that was done recently on the effects of CPM on range of motion. And what they found is at the 6-month mark, do you think they found any difference between a patient that used the CPM versus didn't use the CPM? Riley says yes. You'd be surprised, Riley, they didn't. There is no measurable change. Right. Especially, and they look specifically at total knee replacements. Now, maybe something like a big toe machine might be different. I don't know. But they look specifically at total knee replacements, you know, at the 3-month mark and at the 6-month mark. Now, at the 3-month mark, there was a slight difference. There's about a 10% difference in range of motion. But at the 6-month mark, there was no difference. Well, that kind of makes sense to me because the CPMs we're only going to use for about 4 weeks at most. And then we're going to get them off of it and get them doing active motion. What I find personally myself is I will only like to use CPMs immediately after surgery. I would prefer that we only do them in the hospital if I could. Because, yep.
Sorry. Our OT kind of used a couple of like devices that allows patient to do supination and pronation for the forearm.
Yep.
Would that be considered like CPMs?
It could, if it does the motion, helps them do the motion, yes, it would be considered a continuous passive motion.
So basically, like they had the patient, at least they cranked it to where the patient would do supination, hold it there for a little bit, crank it more.
Yep, that was probably one. There is a CPM that does that, so they probably were on that. There's a strange CPM. I saw that once. I'm like, what is that torture device? It's got a little like wheel on the side. Is that the one you're talking about?
Yeah.
Yeah,
it's crazy.
It does help them get rotated over. Even a hand therapist might use that as well, right?
Okay.
So is there some benefit? Let's say instead of having a patient post-op, now I've got Riley was last in the post. So Riley is now 6 months after her wrist surgery. She's had no therapy, and I put her on a CPM. She's going to get really nothing out of it. It's good immediately post-op, but when you're that far out, active range of motion is so much better at that point. Getting her to do the motion. The other thing you'll find is a lot of times in the hospital, I'll say, come into the patient's room and I'll say, hey, you know, I'm Keith, I'm here from therapy and we're going to get up and get you moving today. And the patient looks at me and goes, I already did my exercises for the day. They point over to their CPM. And I'm like, that's not therapy. Well, then why am I doing it? And I'll look at them and go, because the doc said so. Yeah, I mean, well, it depends. Depends upon the injury. I mean, you can, as long as you're out of that acute phase, meaning the swelling's down, the pain's under control. You know, some people you may switch to active assist range of motion at 2 weeks, honestly, Riley. Right? It just, it depends. And it's going to depend upon their pain threshold too, because maybe you don't react well to pain. But I don't know, maybe we have Amanda, and Amanda has the same injury. She might be doing better with the pain and may be able to move out of it faster. It just really depends on the patient. That's why it's so important for us as PTAs to give back information to the PT. To a point, I'll agree with that. Amanda says no pain, no gain. There's a point to that. There is, but there isn't as well, right? We got to watch that the pain is not bad pain. So with the CPM, the rates can be adjustable. And a lot of docs in this area, you'll find a lot of the ones that do total hips and total knees may order CPMs, and they're just ordering it because they've always ordered it. And that's okay. If the doctor says, put the patient on the CPM, and they'll say, does anyone know how often a patient should go on a CPM for? Anyone have a guess? How many times a day? Anyone have a guess?
I don't know, 3 times?
Close, twice. Usually they want to be on it for twice a day for about 3 to 4 hours.
So a CPM is like it's a machine that, I mean, what's the difference between, is it just a machine that's doing passive range of motion?
Yep. So the knee, and I'll bring up a picture of it. The knee machine has this like cradle in it that they put their leg over it. And there's a pulley system down in the bottom here. And that pulley system will pull that leg back into flexion. And then there's a push system that pushes the leg out into extension, and that pulls it back into flexion, pushes it out into extension. And the machine does all the work for them. They do nothing. And they just lay there while the machine's like, and they think that's exercise. But in reality, because it's passive, not so much, right? The other thing is, once you leave them, they'll cheat in that machine like crazy. They'll try to get themselves in a position where that machine doesn't move their knee as much. And, patients will try to cheat think of patients as like little kids, right? If little kids can cheat and get their way out of things, they do. Patients, same way. And at least in our area, the CPM is 2 times a day. So twice daily, or BID, right? For 3 to 4 hours a day. That's a lot of time. But again, most of our patients, when they're that acute, are just laying in bed anyway. So what I try to tell them is, when you're sitting here watching Judge Judy, get on the CPM and knock it out. Better to get it knocked out and not have the doc up, yelling at you because you're not on your CPM. Right? Get it done with. So when I see them in the hospital, so like total joint replacements, usually you'll see a total joint replacement twice a day. So you'll see them once in the morning, once in the afternoon. So they come up to therapy, they do their therapy. I take them back to the room. I put them on their CPM for the first 3-hour session or whatever. They're on that CPM till lunch. They get up to get lunch with the nursing, right? And then I come back to see them in the late afternoon. They come up, they do therapy again. I take them back to the room. They get back on the CPM. They're back on the CPM till about dinner. Then they're done for the day. That's the usual standard, at least the Las Vegas region, is about 2 times a day, 3 to 4 hours a day for most of the docs in our area. Ideally, you want to set the range of motion, so how far it goes, to a functional range of motion. So for the knee, we're going to talk about this. In order to walk, you need about 60 degrees in order to walk. So at minimum, we want them to 60. But if a patient has to go up and down stairs when they go home, they need 90 degrees. So I'm going to really try to push them to get to 90 degrees on that machine in order to get them safer to go home. When the machine is not on them, they should still have active physical therapy and doing stuff. The devices are portable. Some of them are battery operated. Some of them plug in. And I've got a bunch of pictures of them. I'll show you some of the pictures in a little bit. So don't totally freak out about these. But the main thing I want you to understand is, but from a research perspective, we found out there's not as much of a benefit from these as there used to be. medical sales reps will still try to sell you these because, well, they're trying to make some money, right? That's their job. Our job is to get the patient better. And if I have a patient that says, I don't want to do my CPM, my comment is, then you have to do therapy more frequently, because if you don't want to be on that so much, we got to get you up and moving longer. And if I have a patient that says, great, you know what? I'll do an hour of therapy to stay out of that machine. Great, take it. Because again, active motion is better than passive motion in order to regain stuff. So the different types of self-assisted range of motion we can do, right? Active assist. There, we can use a wand, which is nothing more than a bar, right? Wall climbing. I can put my hand here, right? And I can use my fingers to pull my arm up the curtain and walk it back down. There's things called a finger ladder, which is nothing more than a ladder that goes up the wall, and they can use their finger to pull their arm up to get shoulder range of motion. Taking a ball and rolling it on a wall is actually active assist range of motion. Probably all of you have seen that. In most modern clinics, CPMs are obsolete. Yes, Anthony. I'm trying to avoid saying 100% they're obsolete, but at least in my personal practice, I don't see as much of a benefit as I used to see from them. I would rather a patient do their exercise and get extra exercise than get on that CPM 9 times out of 10. The one area that I do see a benefit from CPMs is pain relief, because it helps them tolerate bending more. So there is some pain relief to it. Ball rolling is a good one. How many of you guys have seen somebody at the clinic doing ball on the wall before with the shoulder?
I haven't seen it in the clinic, but I did that for my home exercise programs. Yeah.
Yep. And then you get right. You have the patient go up and down. You have the patient go side to side, and then the fun one that they love, making circles. Right? Was that fun doing circles with that one? I'm sure you.
It was painful.
Yeah.
I hated it.
Exactly. Right. You don't think of something. You think that's something simple, right? And you're like, oh my god, that's easy. And then you go do it, and you're like, this sucks. You do the same thing with a foot. I can roll if I'm having a knee injury. I can put a ball under my foot and roll it on the floor as well to get some active assist going. Overhead pulleys. We've all seen those, and we'll actually practice a little bit with those, right? When you pull on that pulley with the right hand, it'll help get that left hand up and stretch it. And you can get a nice pull on that and get them moving. A skateboard can be used. Powder boards can be used. A reciprocal exercise unit. This is a fancy way of saying something like this. Elliptical. Why is an elliptical a reciprocal exercise unit? Well, if I push forward with my right hand, my left hand comes back, right? Or if I pull back with my right hand, my left hand goes forward. I can move my feet and move my arms. Does anyone know what the exercise machine is that old people love and will fight over in the clinic?
Recumbent bicycle?
Maybe recumbent. Okay, you've seen UBE fights? There we go. Oscar said it right there. The new step. Right? The new step is honestly like, those are fighting words. They'll start swinging canes at each other over it. Yeah, Stephanie says new step and there's lines for it. I'm not, would you guys agree, right? Oscar, would you agree with that? If you like, they get kind of protective over their new step time if you've seen them on it. And Stephanie, same thing, right? Because the new step, what it is it's a recumbent elliptical. So they're able to sit back like I'm sitting in a chair here, have their feet on basically little pedals that push back and forth, and then they have arm pieces, and they're able to go back and forth. And it's a great device. It's a very low impact device, right? But it gets reciprocal movement going, and it's really good for them, right? It's like a whole body movement activity, even though they're sitting, right? Obviously, a bike or a treadmill would be more beneficial because it requires a little bit more weight bearing and stuff like that. But if we can even get them on that new step, that's something, right? Get them doing motion, because that's the main thing we need to do is get them doing some cardio activity to keep them heart healthy and keep their bodies that, you know, we learn, if nothing else, we'll learn that motion is lotion. Yep. Right. Getting that body moving is a huge thing. So the more they're able to do that, and I'm not joking. In some of the the skilled nursing facilities I've been in, they've got like 3 new steps, and Stephanie's right. There's like old people sitting there with their walkers and chairs behind the new steps. They're like sitting there waiting to get on that new step. They want it. It's like, it's mine. This is my therapy hour, right? Especially if we can put prices right up on the TV ahead of them. It's all we need to do. They'll sit there and watch, there's that Drew Carey, I think is the host now. Sit for hours watching him on Prices Right while they're on new step. And you're like, okay, Mrs. Johnson, your new step hours are over. No, I want to do some more. Oh, went too fast. So we talked about some indications. What are some contraindications? So range of motion should not be done when motion is disruptive to the healing process, specifically in that early phase of healing, right? In that acute phase. We've got to be careful. Passive may be more better. That's a great term. Good job, Mr. McKeever. Maybe better for that patient than active at that point. Range of motion should not be when the patient's response or condition is life-threatening. You know, you come into the hospital and you're like, knock, knock, knock. Hey, Mr. James, I'm here to do therapy. And he's like, I'm having a heart attack. That's okay. We'll just do some passive range of motion with you. No, that's the wrong time to do it. Call it code, right? Or if patients have it, you know, in the process of having blood given. That's another, that could be life-saving, right? We've got to be careful when we're getting that type of stuff. Follow those very specific precautions. If a patient has a DVT, we've got to watch how much we move those lower extremities, because even something as simple as doing passive range of motion at the ankle could cause that blood clot, that right, to actually take and break loose, become an embolus, and go floating through the system. Back when I was in Pennsylvania again, we had this, I'm going to say, very large lady in the hospital. She was probably 5'2", but she was easily 400 to 410 pounds. So, you know, like this tall and big, right? She came in because she had a mini stroke, a TIA. And so we were supposed to come in and see her for physical therapy, but she was kind of bigger. And I'm like, you know, I'm going to get some help here. So I got the OT to come with me because the OT had to do some ADL training with her. So I'm like, great, we'll go hit her together. There's 2 sets of hands. The OT's like, I'm not going in there without the third person. So she brought her tech along with her. I'm like, we got 3 hands. We've got this. And we were getting the patient up and transferring her over to a chair. We checked the chart first. There was no warnings in the chart. And her general medicine doctor says, I want her out of that bed today. Now, I couldn't get her out of the bed because I had no PT orders for it, but they had OT orders for it. I could be there to help the OT get her out of bed, but I was not going to document or bill for any of that getting out of bed because I had the PT had never seen it. So I can't do that. At that point, I basically became a glorified tech. So we get the patient standing. She's doing good. We're like, how are you feeling? I'm feeling really good. Right. So she takes her little shuffle steps over to the chair. And we trusted the tech that we had in there to do the most important thing. What do you think one of the most important things is you want to do with the chair? Because the chair had lock it. And she didn't lock the back wheels on the chair. So the patient got to the chair and plopped her butt down. Boom. But when she plopped her butt down, she came out on the end. And guess what happened to that chair? It became a rocket and shot literally across the room because of her weight. And so she slid right out of the front of the chair and landed on the ground. And, you know, that's a fall. That's bad. But the good news was she took it just absolutely great. She just started laughing. She's like, that was the funniest thing that's happened to me in years. And she's laughing and we're laughing. And I'm going, oh God, that was a fall. I'm going to have to go before a sentinel committee. This is going to suck. But at the same time, I'm laughing because she's laughing. She's not hurt. All of a sudden, she stops laughing. And her eyes roll back into her head. And she just flops flat on her back. And we're like, what the heck just happened? So the OT takes pulse. We have no pulse. How many of you guys at this point, this is happening to you, you start freaking out? Yeah, scary, right? And so we start doing CPR. We call a code. Nurse comes in. We start switching off 2-person CPR, waiting for the aid or the paddles to come in. The doc comes in with the paddles, yells at us because the patient's on the floor because we haven't been able to get the patient up. That is a code blue, right? Yeah. Anxiety's kicking in. You're right, John, right? Just even talking about this, how many of you guys are getting a little anxiety about it? Right? So doc comes in. The first thing doc does is doesn't even look at the patient, starts yelling at all of us because the patient's on the floor. Why is this patient on the floor? Why are they not up into the bed yet? Well, because we're doing CPR on the patient, doc. We don't have any paddles. What do you want us to do? Right? So at that point, the nurse was doing CPR with one of the CNAs. So the OT and I go run to the closet and get some draw sheets because we don't know where the lift is. We couldn't find the lift. Get some draw sheets under the patient while they're doing CPR. During the breath phase, we get some sheets under her. We lift her up into the bed. She's coming back. She gets a pulse. It goes away. She gets a pulse. It goes away. They shock her like 4 times. We did compressions on her and shocking for like 90 minutes. And finally, the doc's like, yeah, we're calling it because we get to the point where it's just not feasible anymore. We find out that morning she had gone down for a Doppler ultrasound and she had a blood clot that went from her ankle all the way back at her Achilles tendon, all the way up to her groin. So basically, most of her veins in her legs was a giant blood clot. And the doc had never indicated that on the chart. We didn't even know she had gone down for an ultrasound on it because that wasn't put on the chart. Because if the OT and I had gone in there and it said, patient sent for ultrasound, suspected DVT, the OT and I would have went, nope, we're waiting until we see what that ultrasound looks like before we even move this patient. But man, the doc was breathing down our neck. You got to get her out. You've got to get her out. She's out of bed today. She needs to stop being lazy and get out of bed. So we got her out of bed because we had no contraindicating orders to get her out of bed. Right? She stroked. She actually sent, I think it was like a 4 or 5 inch long blood clot to her brain. And she never recovered from it. Right? So that's why it's really important to understand if they've got a condition where it's life critical, we've got to be careful. Right? So that's why reading the chart's really important. And even sometimes when you read the chart, sometimes bad things happen. It's just the way life kind of goes. Right? I've done things perfectly, read the chart, and things go all askew when I'm in the room with the patient. It happens. You kind of have to do what you got to do, right? But if it's life-threatening or critical, right? Or we go in, and does anyone know what I mean when I say H&H counts? The doctor was ultimately at fault. Yes, you're absolutely right, Kirsty. That was not our fault. Although we had to go, we did get kind of yelled at for her ending up on the floor, right? Well, that was 100% our fault. That's actually 100% the OT's fault. But I won't say that. We all took kind of responsibility for it. That was our fault for the fall, right? But the blood clot was 100% the doc that did, the hematologist that didn't put in that they ordered it. They literally, I guess, evidently saw the ultrasound tech and said, hey, take them down for a blood clot, never put it in the chart. Right? That's kind of scary. But sometimes stuff like that happens. It is what it is.
Mr. McKeever, when somebody's like that overweight and you're gonna take them out of you're gonna transfer them for the first time. I know like in hospitals they always say like use a 2-person assist, but can you use a machine as well?
Absolutely.
Depending on their surgery that they're in?
Yeah, and that's the thing is in a lot of states right now, Nevada's not quite one of them, but I think it's gonna come very soon. Like in Pennsylvania, about 6 months after this happened, we switched to what's called a no lift state. And what that means is to prevent injuries in the hospital, if the patient was ever a max assist or dependent assist, or was a 2-person or over transfer, we had to use a lift to get them out of the chair in order to save the clinicians, right? So we don't get injured. Now, eventually, obviously, we want to try to train them to get out on their own, but especially like in that early phase, yeah, that lift would have saved us a lot of work. But at that point, she's like, yeah, I walk. And she told us, she goes, I walk on my own. I talk on my own. I normally do stuff on my own. And when we got her up, she was golden. Like literally, as soon as we got her standing, we got that weight off of her, because when she's laying back, obviously all that weight's a lot of weight on her, right? Just imagine that. You have 400 or 500 pounds pressing down on your organs. Can you imagine how much that must feel like you're suffocating? You know, we get her upright sitting at the edge of the bed and she's like, man, I feel so much better. I can breathe better. And then we get her standing and she's like, this is awesome. And she starts taking her little steps and she loved it, right? But it is sad. You're right, Amanda, right? There's a lot there that could have been done differently. And we all had to sit for that committee and talk about what we could have done differently, what we could have done better. It happens, right? I've been part of one of those committees where I've had to talk about what I could have done better. You know, what could I have done better there? Well, for myself, we could have used a lift, right? That probably would have been the better option to get her out to the chair at that point. Even though we had 3 people in the room, one of those people was a non-skilled worker. We probably should have had maybe 3 people skilled worker that size, right? We'll talk about when I broke my neck in the future, that I should have had more help in when I broke my neck, because I was transferring another person that was about 400 pounds, 500 pounds that day. And I transferred them all by myself. So all of that comes into play when you have those things happen. But if the patient's critically wounded or critically care or critically severe, that's not a time to do therapy with them, right? And I can go back to my original question. Does anyone know what an H&H count is? It's hematocrit and hemoglobin. That's talking about your red blood cells, right? It's the ability for your red blood cells to transfer oxygen to your tissues. If you have a low H&H count, your body can't transfer oxygen out to your extremities. If it's not transferring blood out to your extremities, you probably don't want to move them, right? Because that's bad. So maybe a lot of times when they have low H&H counts, we're waiting on a blood transfusion for them to get, you know, a couple units of blood in order to pack up their blood cells so that their H&H counts come up. What happens if, you know, you go in to see a patient? So Amanda's my patient. I go in to see her and I'm like, hey, you know, we're going to get up and get you some movement today. We're going to do some range of motion. And Amanda's like, that's great. You know, just one question. I fell last night and broke my hip. Is that important? That's important. Yeah, right. Maybe we're going to hold off on doing range of motion because their status has changed, right? Say, yeah, let's wait. Let's get the PT in here and make sure you're okay to do range of motion with her, right? So you'll find this in the hospital setting, and I know Dr. Sokel will talk to you a little bit about this. If a patient gets worse or has a decline in status, it's hard to write on this dresser that I'm using as my desk, has a decline in status, meaning they've gotten worse. So maybe they were on, you know, the regular floor in the hospital. So they're on the regular floor and now they've gone to the ICU. Can we as a PTA, even let's say the PT saw them here on the regular floor, but now they're in the ICU. Can we go see them in the ICU? Good answers, right? What has to happen?
A doctor's order, maybe?
We have probably get to have new doctor's orders. Yep. And the PT is going to have to see them for a what?
Evaluation.
Yeah. Evaluation, or more importantly, at that point is a re-eval, right? Because their status changed. If they've gotten worse or they've declined, you know, or like I said, Amanda broke her hip. That's a decline in status. Even if she's still on the regular floor, right? But she's broken her hip now, that's a decline in status. The PT has to go see them again before we can see them as a PTA. And that's okay for us to say to the nurse, hey, the patient's had a decline in status. I've got to get the PT to come see them before we can really do much with them. And the nurse is going to go, oh, but you know, Diana, you and I work so well together. Can't we just get her out to the chair really quick? And Diana should say what? No, yes,
No.
exactly. Your nurses will they're trying to be nice and sweet to you. Oh, come on, John, I'll bring you some cookies tomorrow. Just help me get her out to the chair, right? I can't see you exactly, right? You got to do the John Cena, I can't see you, right? You got to be careful. Now, let's say instead the patient has gone from ICU and now they're up on the regular floor. Now their status has improved, gotten better, or their status has improved, can we still see the patient?
No.
I would still wait.
Yeah, actually, now we can. So actually, they don't have to do a reval now because the PT saw them when they're at their worst. Right? Now, let's say they've achieved all their goals. Maybe here in the ICU, they only had ICU goals. Yeah, then they have to have a reval. Right? But if the PT has already set some long-term goals for them to get out of the hospital, then yeah, they can actually we can go see them perfectly fine.
Oh, are we talking about like, so if the patient goes from the regular floor to ICU and then back to the regular floor, they don't have to do a re-eval?
Yeah, so well, it depends. So in that case, that's a great question. If they've had a re-eval in the ICU, then it's okay. But if they went to, say, regular floor, ICU, and now they're back on the regular floor, that would have to have a re-eval before we see them if they didn't have one in the ICU. But let's say they came in. So, John was last on the post, so he's going to become my patient here. Hold on one second. I am having, what's going on with my camera? It's hiccuping here. Hold on. I know you guys can see me, but mine's actually kind of hiccuping. Where'd my mouse go? There it is. Okay, I found it. So my video is cutting out for a second. So just give me a second while I talk about this. So I'm just resetting my camera. So in the case where the patient has gone, maybe they came in, they're in the emergency room. There's the word I was looking for. My God, my brain is not working because I was doing two things at once. All right, I got the camera rebooted. There we go. Okay, back. Good. They came in the emergency room. They went straight to the ICU, right? So they went from the emergency room. They had COVID. They went straight to the ICU. The PT has seen them in the ICU. They did their evaluation in the ICU and have long-term goals set for them to go home. And now they get better. They go out to the general floor. At that point, when they go out to the general floor, we don't need a re-eval for them because the PT has seen them at their worst. And we're eventually going to get a re-eval anyway after about 16 visits or whatever the hospital requires. So they're going to get one anyway eventually. Right? So that's not going to require a re-eval. But let's say, like somebody said, they were on the regular floor here. Where am I writing at? Oh gosh, I just went forward. Right? This is just not cooperating today. Oh, I don't. Oh no, because I lost my drawer. That's why. So here we go. So they were on the regular floor. They had their eval here. So here was their eval. Then they went to the ICU. And then maybe a day later, they came back to the regular floor. But they did not have an eval here in the ICU. Then they need a re-eval. Does that make, okay, John says that makes sense, right? But if they went from the ER straight to the ICU, and the ICU is where they had their eval, but 2 days later, they're on the regular floor. Regular. We can see them. They don't need another eval there. Because again, the PT saw them at the worst, unless of course they've achieved all their goals or they've met the point where we're going to talk about when they need a re-eval based upon time. Does that make sense? Did I lose anybody?
Makes sense.
Okay, good.
So let's say in the hospital they have like 16 visits and the only the PT as well does the re-eval, not the PTA, correct?
Yeah, we don't do the re-eval. Now we may take measurements for the re-eval. So maybe the PT might say, hey, you know what? Can you do me a favor? Start your treatment right off the bat. Go in and get me my range of motion, my manual muscle testing, and cranial nerve testing. I'll be in to finish out the re-eval. We can get all the measurements and just say, I made these and give them to the PT, right? And the PT is going to take all those new measurements and come up with a new evaluation or re-evaluation for them, right? We can help there, but we can't do the full re-eval. The PT has to write most of it at least. So now how about let's add one wrinkle in here. So let's say we're now at an outpatient clinic. So we're now an outpatient. Patient comes in to see us and say, I don't know, let's say it's 3-1. That was when their eval is, right? And now where it's 3-9 and they're seeing us, they've had 2 visits here with us since then, right? So now they come back on 3-9 and the patient says, the doc wants my shoulder seen as well. Maybe this, so they're in for a total knee replacement. That's what they're seeing as an outpatient. And the doc says, shoulder assessment as well. What has to happen there? Yeah, they have to have an eval. Good, right? It has to be a separate eval, right, John? So it's going to be a totally separate treatment plan, right? We're going to now, and that's going to get fun because now we've got, it's kind of like where we have right now the 3 classes. Well, with this patient, it's going to be fun. It's going to be like Monday and Wednesday are going to be your total knee replacement days. And then Friday is going to be your shoulder day. It does get annoying a little bit at that point, right? And sometimes that can be better if your clinic has separate clinics that handle upper body versus lower body. So we can say, okay, well, you know what? For your shoulder, we're going to send you over to the Charleston clinic for your shoulder. But for your knee, we're going to see you here in the Henderson clinic, right? Because that just kind of keeps things separate. And then they know when they come to Henderson, it's only for their knee. When they go to Charleston, it's only for their shoulder. So anytime that happens, we have to pay attention because sometimes those notes will come in from the front desk and your front desk doesn't catch it. Because it happens, right? The front desk gets busy. If any of you have ever worked the front desk at a PT clinic, it gets pretty busy pretty quick. And so we're looking through the chart. We see, you know, we go and we see Diana and it's like, oh, Diana's got a thing in here for the doc to see for her shoulder. We may have to call up our PT or talk to the PT and say, hey, you know, Diana needs scheduled for her shoulder. Do you want me to, you want to do it now? Or do you want me to schedule for a future visit so you can eval the shoulder? Right? Because the patient's shoulder told us earlier. Yeah, it may need separate documentation. Absolutely. Yeah, it may be the same chart, maybe the same like charting system. So they may still be going into Campus or maybe going into Web PT or whatever, Clinicent, but it'll have separate documentation system. Like there'll be a different tree that it goes under basically.
And if they're not, sorry, I'm into this whole lecture for some reason.
Like
if they're not completely injured, and the doctor does want them for the PT or PTA to see their shoulder, can you just do like home exercise programs for them at the moment? Right. Or
yeah, maybe the PT might do that. The PT might say, yeah. So John says they use separate flow sheet for it, right? Or flow chart. The PT may come and say, you know, they may come in, take a peek at their shoulder and say, you know what, we really don't need you to see you for PT for this, but I'm going to give you some home exercises to do, right? That's going to be the PT's discretion to do that. And he may say, you know what, give them ball in the wall vertically, horizontally, and circles until we finish up with the knee. Because maybe he wants to finish the knee first because, and if John's seen people in the clinic or actually been in a clinic like that, sometimes we have to finish out one kind of treatment before we can start another treatment as well. So the PT will say, I'm going to give you some home exercise program for now. We're going to finish out. You got 2 more weeks of knee treatment. And then once those 2 weeks for knee treatment are up, we'll start your shoulder. Because it can be really difficult. A lot of times insurance companies will say, well, hey, they're already being seen. Why are you seeing them twice? Right. And so it's a lot easier to separate things out. But that's great. I like that you guys are into this because this is kind of the real life stuff. This is the real life nuts and bolts of doing PT. Right. This is the real stuff. This is not the fake stuff anymore. We're getting the real stuff now. So when we do an examination, well, again, we're not going to do it's going to be PT, but when we, as in the PT clinic, does an evaluation, the PT is going to determine the appropriate level of range of motion. They're going to kind of document what's safe. And then the pattern to get the goals where they want to get. They are also going to have to monitor the range of motion interventions. They should be checking what you're doing on a daily basis because PTs have to sign off on your notes. When you guys go out in the clinic as students, Some clinics will require not, say you have a PTA. So say you go to Select, because I know Select, and you're going to the Select right down the road from our school. I know the clinic director there. It's Mr. Gersh. He's actually one of our adjunct faculty that comes and helps us with the labs. He's a PTA. Say he is your CI. He has to co-sign on your note, but not only does he have to co-sign on your note, but your PT has to co-sign on your note. So there should be checking to make sure they're monitoring the intervention. Doesn't always happen. Sometimes we have to kind of hint and say, hey, Mr. PT or Mrs. PT, hey, Anthony's gotten really good with his shoulder stuff now. Can we add some new goals so we can get better? Sure, they can do that, right? And they'll modify and reevaluate as appropriate. When we're working with the patient, we have to tell them what they're doing, explain the intervention and how it's going to meet their goals. We have to clear up the area, get everything out. If we're doing range of motion, we may have to drape them because we want the patient in the least restrictive clothing as possible. I loved it when I had patients that came maybe from, they're working down at the Bellagio and they've got a hip problem. So they come in straight from work and like they're in a tight pencil skirt. I say this is legitimate. It has happened to me before. Yeah, like for those of you guys that don't know what a pencil skirt is, I wish I never had to learn what one is either. But it's really one of those really super tight skirts. I can't do therapy effectively if you're in one of those. It's just not. Or maybe they're wearing skinny jeans. I've had patients come in skinny jeans before. That's loads of fun, right? I may have to put them in a gown. If I have them in a gown, that means things can be exposed. You want to make sure you drape and cover those areas. Maybe you're in the hospital and all your patients are in gowns. I'm going to tell you, most of the time that a patient is in a gown in a hospital, they have no undergarments under there. So, if you're doing range of motion of the hip, every time you externally rotate that hip, everything's on display for anyone in front of them. So make sure you drape appropriately. And not only drape appropriately for everyone else, but let's say John is now working with a female patient. She may feel more comfortable if John is draping her so even he doesn't see places he shouldn't see, right? So be aware of that. I'm going to warn you guys especially. Ladies, the reason I will warn you about that is because guys take things the wrong way. Let's just face it, right? And so, you may get inappropriately accosted if you don't appropriately drape is kind of what I'm getting at. And I hope you understand what I'm getting at that point, where they may make comments that you don't want to have made at you. And we'll talk a little bit about that as we go through here about how to deal with patients that get a little inappropriate with you or a lot inappropriate, how you stop it. We're going to position a patient so they're best in alignment. If I have to range motion the shoulder and the patient is all the way over the bed where I have to climb up in the bed and do it, it's not effective for me. I've got to move them where my body mechanics are also maximized as well as their body mechanics. Position yourself for proper body mechanics. Remember this. If you don't position yourself for proper body mechanics, you are going to be in the bed beside the patient sooner than later, right? Especially for your low back, right? Bring those tables up to your waist level if you can. Bring them as close to you as you can. Save your low back. Please don't injure your low back, because once you get an injury of your low back, it kind of nags and lingers forever. How many of you guys have a low back injury right now or have had one recently? John, yeah, right? And it only takes now, once you've injured it once, it only takes, as the French would say, un petit peu, a small bit of something to tweak it again, right? Sometimes it just takes getting out of bed when you get to my age. Right? So you've got to pay attention to that. Use good body mechanics when you're working with a patient. I had a patient, I injured my back the worst working with a stroke patient in parallel bars. We were working on standing in the parallel bars. He was a very aggressive and angry traumatic brain injury. And all of a sudden, when we're standing up, for whatever reason, I became his ex. I don't know what happened. He suddenly saw me as his ex. I started calling me by her name, and he just backhanded me across the face and sent me flying over the parallel bars. And when I went flying over the parallel bars, I tweaked my low back. And man, I remember that day I was sitting at home, I was watching a Green Bay was Green Bay, I think, versus Atlanta. And I went to stand up and I pushed up from the chair and I realized my legs didn't work. They were just like, the best way I could describe it is they felt like, you know how when your legs go to sleep and they weigh like 1,000,000 pounds? Have you ever gotten that bad? Well, that was my whole leg, both of them. And I was like, ooh, this is not good, right? I tweaked my back that bad. So save your back. Don't injure your back. Don't do what I do is basically what I'm saying. When you're moving the patient through range of motion, you want to control the movement. You don't want to be doing any accessory motion, right? If I'm doing flexion, I want to do flexion. I don't want to do rotation with flexion. I want to do flexion and get me through it. Support areas, poor structural integrity. If they have a fracture, you've got to protect it. Move the segment through the pain-free range of motion. Again, range of motion goes to the point of resistance. It should be smooth and slow. And then repetitions are determined by the plan of care that the PT is going to set for you.
So Mickey, we got a question on that one.
Yep.
So like that's one of my like concerns as well too, is like, for example, like an empty end feel, right? With,
Yep.
like with pain, which is the patient saying us pain. How would we know, like, do we just kind of
So if
base
you're
it
just
off
doing
of-
range, if you're just doing range of motion, that's a great question. So what I tell my patient is, so this is the next, we're going to talk about it because one of the big things I will preach to you guys until you are done here with me, again, once I find my mouse again, there it is, and this is my little joke. And if you ask the other class, they'll tell you this too. You are always going to give your patients the STDs. The show, the tell, and then have them do it. So I'm going to show them. I say, all right, John. Well, so today what we're going to do is I'm going to move you into flexion. So that looks like this. And I'm going to work on abduction. That's coming out to the side like this. Both of them, your thumb's going to be up. Now I'm starting to tell you, right? Both of them, the thumb's going to be up while we're doing it. All I want you to do for me is relax. I'm telling you again, I'm going to do all the work for you. What I want you to do, because you're in so much pain, tell me when I reach a point where you can no longer tolerate the pain, because that's where I'm going to stop, right? If it gets really bad, and that, again, that's going to be subjective, right? For Diana, it might be really small range of motion. For Ryan, he might tolerate a lot more. So you're going to say, tell me when it gets really bad. So let's do the first repetition really slow. Okay. So tell me when you first start feeling pain. Okay. Start feeling it right there. Okay. Can you take a little bit more? Yeah, just a little bit more. Okay. I need you to stop right there, John. And I'm going to note. So I'm about 90 degrees. That's where I'm going to stop. And then next rep, I'm going to stop just a little bit short of that. Right. Because again, range of motion, the goal is just to keep the motion and the lotion in the joint. Right. So we're going to go through it and then we're going to do it. Okay. We're going to go through this. Okay. Now we're going to do abduction. So again, we're going to come out like this. So you tell me as soon as you get to that pain point, oh, I'm good. I'm good. I'm good. Okay. Start feeling pain there. I'm good. I'm good. I'm good. Oh, right there. It really hurts. Okay. So we're going to stop back here. Don't worry. And we're just going to go to that point, right? We're going to do butterflies out to that point. Does that make sense?
Yeah, that makes sense. Thank you.
Yeah. So it's going to be a really slow process, right? Especially with the empty end feel. You're going to have to kind of slow it down and say, okay, let's slow it down a little bit. Let's see where you can tolerate to. Right now, what happens if you're like, that's as much as I can tolerate. It hurts too much. Those are the patients I'm going to say, tell you what, how about we put a hot pack on that shoulder or put a cold pack on that shoulder while we're doing it? Because why am I putting that on? What am I trying to do?
To distract them?
Yeah, you're exactly correct. That's 100% my reason. Now, I know that a hot pack or a cold pack, depending upon where they are in the service or, the treatment plan, could relieve some of the pain, could do some good things for them. But the main goal of that hot pack or cold pack is to distract them, right? I'm going to use gait control on them because they're going to focus on that hot pack or that cold pack and not focus on me moving their shoulder. Or the other thing I might do is I might rub their shoulder while I'm doing the motion a little bit to trick them, right? So there are some techniques that you'll learn, but when they get to that point where like, no, you can't go any further, that's it. That's as much as I can tolerate, you stop. I remember when when I had my first surgery, I really had problems going to my left. And even to this point, that's about my maximum for my left. So I have a huge blind spot when I'm driving to my left, right? But when I first started, I was like, there, I'm like, okay, yeah, you cannot, my right, no problem, that's good. But my left, man, he was like there, and I'm like, okay, dude, you've got to slow down on that. And that PT was like, whoa, let's go here. And he's like, let's have the tech touch your neck. Don't you let that, don't keep them away from me, right? So you're gonna kind of keep it, just kind of in that range of motion. Okay, good, I can handle that. And you may find, John, that as you're doing that shoulder range of motion, they're able to tolerate it a little bit more, right? They're like, oh, you know what? You can take it a little bit further now. It feels a little bit better now. Do it. Take it to the next little step. You're not, as long as you're not getting a stretch there while you're doing it, if it's kind of still just that you still got some space feeling, take it a little bit further. But always give your patient the STDs. I mean, the Shotel Dews. That just sounds wrong, but that kind of makes me laugh, and it'll keep you guys remembering that.
And you said you would add that under assessment?
We're almost there.
Okay.
Almost
I'm
there.
thinking about soap notes.
You are 100%. We're almost there. Right? So when we're applying it, it should be segment by segment, meaning that if I'm moving them through range of motion, passive range of motion, I should work on the shoulder and I should work one motion, right? I should work flexion. I shouldn't be doing flexion and abduction, right? Or maybe we're going to talk about scaption, which is a 45-degree angle motion. I'm only going to be moving kind of one planar. That way it kind of goes in step and sync. So I'll do flexion first. Now I'll do abduction. Maybe then I'll do external rotation. Then I'll do some internal rotation. Maybe then I'll do some horizontal add and some horizontal abduction, right? You're going to do the motions individually. So we're going to go over one of the, I think that's actually our third lab, or our second and our third lab. We're going to go through the positioning and techniques for most of the lower body and most of the low back passive range of motions. So we're going to practice that with each other. So we're going to position them appropriately for each of those. And again, the main part about positioning the patient, you may think it's to make the patient comfortable, but it's to protect yourself. The goal is to make it as easy as possible on you. Daniela is an excellent example. Daniela's kind of, well, actually, even most of you young ladies are kind of tinier. If you have to move my leg is about 100 pounds by itself. You're going to have to put yourself in a position that is going to make it easier for you, right? You may, instead of lifting my leg with your hand, you might have to lift it with your shoulder so that it saves your back. Dr. Reskin's an excellent example of it. I love that she's in my lab because I often don't think about what happens if the patient is bigger than me. John may not think about that. I'm not saying John is huge, right? I'll be lifting my pinky, exactly, right? But John may not think about that until he encounters somebody that is truly bigger than him, like until he encounters a patient that their leg is 200 pounds. And then he's going to be like, oh, this is how Daniela felt moving my leg. Yep, there are ways to move bigger people, and we're going to talk about that. And that's why I really love having Dr. Reskin in this class, because I present it from kind of, monster, big bear perspective. And she presents it from a little bit more of a petite perspective because we're definitely built differently, right? And if you are petite, you're going to fatigue out quicker. Yeah, lifting at the gym can help you for sure. Absolutely, Bianca. But even that, there's a limit to it, right? Because lifting at the gym, right, using your legs is good. Using your whole body is good. Dr. Reskin is going to tell you, ladies especially, this is not a working surface for you. Right? So the one area you want to watch is your chest. Right? Now I'm going to tell you, and this is my personal thing, and you'll find out very quickly in the inpatient world, that may not always be the case. You may have to use your chest or specifically like your upper shoulder to motion a patient because they're bigger than you. You may have to put a pillow there and still use your chest, right? What she's basically saying is don't put your breasts directly on a patient. That's really what she's saying. I don't think about that because that's not something I think about, but I appreciate having her in the class because she gives me a different perspective I don't think of, right? It's not like we're two guys going at it, teaching you guys. She gives me a perspective I don't always think about, right? She thinks about hair too. I often don't think about hair. I wonder why that is. Right? See, that's another thing you guys are gonna have to think about. When you're in the clinic, how should your hair be?
Tied back.
Yeah, pulled back and up, preferably, especially if you have like really long hair. I would even tuck it up into put it in a bun or tuck it into your shirt. Yeah, no long ponytails. And I'll tell you the reason for that. When I was doing wound care back in Pennsylvania again, we had this guy that had an abdominal wound. Whole belly was opened up. And I had a student, and we were going in and we were doing cleaning out of that whole abdomen, and we were redressing and packing it. And I told her multiple times, she had hair that came down to about to her waist. Daniela's like, oh no, she can see it already happening. And I kept telling her, pull it up into a bun or tuck it into your shirt. Pull it up into a bun or tuck it into your shirt. Or put it up in one of those, the bouffants, the blue hats. She didn't listen to me, and she didn't listen to me, and she didn't listen to me. And at some point she had to learn a lesson. So we're in there working with the patient, and she was down in there cleaning the wound. And the next thing I saw was the hair's kind of sliding down her shoulder and sliding down her shoulder and sliding down her shoulder. And into the wound it went. Yep, splat directly into the wound. And then she stopped for a second, looked over, saw her hair there, and freaked out and flipped her head back to pull her hair out of it. When she flipped her hair back, it went around her head and came back and smacked herself in the face. Now, luckily, she had a face shield on, but now she had goo all over the front of her face shield from the wound. Moist, yeah, right? Guess what? The next day she came in, guess how her hair was done? It was pulled up in a real tight bun. Oscar's like, but, right? You guys don't think about that right now because we're going to be working with students. But when you get in the real world, that can happen. I'm just chopping all of that out. Don't be that girl, Diane. I love it. Amanda's protecting you. I don't ever have to think about that. But when I go into, a clinic, guess what? I have to put a bouffant on this. Because think about it, even this, when I'm leaning into a wound, this can get into the wound. Right? And so I usually I'll twist it up and I'll tuck it up into my mask, or I'll put a bouffant under my chin to protect that. Because I don't want my goatee even getting goop up in it. Right? So you've got to kind of pay attention to these things when you're working with patients. Even when you're doing range of motion, like if Diana's doing range of motion with the patient and her hair falls forward, it can get caught while she's doing range of motion and she can yank her hair really bad. So she's got to kind of pay attention to that as well. I'm just using because somebody already called you out for your long hair, Diana. Sorry. Right? So you're going to position the patient and transition as needed. We're going to show when we position, when we transition. With application, now we're going from passive to active. Again, we're going back to, we're going to do the STDs, right? We're going to show the patient the active motion. We're going to tell them exactly how to do it, and we're going to have them do it. The first time they do it, they're going to do it nice and slow. You're going to provide any cueing, whether tactile, meaning being on them, or verbal to make sure it's nice and smooth, and then let them do it. Motion should be, again, within pain-free range of motion. What kind of techniques do we have for range of motion? Well, we have upper extremity techniques, working the whole shoulder girdle. So when I say shoulder girdle, what am I talking about? Which are my bones there primarily?
Scapula and humerus.
Actually, we're going to avoid the humerus right now. What other goes along with the scapula? So we've got the scapula.
Clavicle.
Clavicle, good. Right, that makes up the shoulder girdle. That makes up our glenohumeral fossa, right? So that's kind of our girdle. And also the ribs, because the ribs the scapula moves on the ribs as well. So we'll consider the ribs as well. Because there is what's called the scapulothoracic junction, where they come together, right? So that's the girdle. Then we get to the true shoulder joint. Now we're talking the glenohumeral joint, right? Where that humerus comes up in and meets the scapula. Then we've got the elbow, right? We've got the radio-ulnar joint, which is a rotational joint. We've got our wrist. Our wrist has got a bunch of different motions, right? Then we have our hand. Our hand has motions that doesn't include our finger, right? That lumbrical grip style. And then we have our fingers, or our phalanges. They have their own motion. When we get down into the leg, we have the pelvis. The pelvis itself has certain motions, right? Then we get to the hip, which is where we're talking more about the femur into that pelvis. We have our knee, right? And with our knee, we're going to add in the patellar motion as well, because there's some patellar motion that goes with that. We're going to go down from our knee down to our ankle. We don't have as much, well, although we have radial ulnar motion here, we don't have as much tibiofibular motion, right? Because they don't rotate like this does. That would be really weird though, wouldn't it? It's all of a sudden we could point our foot completely. Oh, I can put my foot completely backwards.
Sorry.
Go away, Siri. Do not say anything. Be quiet. Shh. Good Siri. But wouldn't it be weird if like we had,
Why do you have, no, I'm sorry, no.
yep. Why do I have what? No, go ahead and ask.
No, the series so scary. Like they're hearing your conversation, Mr. McKeever. Like
I know. Well, my conversations are kind of boring, so she can hear whatever she wants, right? I like to say that my NSA agent is Bob that's listening to me all the time. And we get that hind foot motion, which is back at that posterior, the calcaneus and the talus, right? We have some midfoot range of motion when we start getting into those cuneiforms. We have the forefoot when we get up into our metatarsals. And then we have our toesies, right? Our phalanges of our toes. With cervical motion, we have upper rotational, right? Where does rotation occur on the spine? Do you remember? At the neck? Where at? Which joint?
C1, C2.
Good, C1, C2, right? It's the axis rotating on the atlas, around that dens. And then once we move further down the cervical, right, we have some flexion, anterior, posterior, we have some lateral flexion range of motion. Thoracic, we have a little bit of thoracic flexion, right? But primarily we have a lot of kind of side bending. We get down to the lumbar, we have some flexion. We have a little bit of side bending down there. What about when we get down to the sacral area? Do we have a lot of motion down at the sacrum?
No.
Yeah, no.
not really.
Right? Not really. Now there are some sacral mobilizations we can do.
Would like your pelvic tilts?
Yep, some pelvic tilts a little bit, right? We can actually even get in and mobilize the sacrum a little bit, meaning mobilizing the whole sacrum itself, not individual segments, and do some sacral mobs where it's more like the sacrum moving on the lumbar segments. And for some patients, that feels really good. Now, again, those are going to be mobilizations that probably are out of the scope of practice of a PTA. But when I say we, I'm talking PT in general, right? We can definitely mobilize it. I question, there are certain PTs that say, well, I can mobilize every single segment of my sacrum. That's just like people that say they can still mobilize the what do you call it? The cranial sutures. If you can mobilize the cranial sutures, I'm not so sure about that, right? So be aware of that. So there's lots of places we can do range of motion, right? And we're going to go through in this class primarily, when we talk about it, we're going to do a lot of this lower extremity stuff and down here in the lumbar spine. Now, Dr. Ovreskin is going to continue the lumbar spine, then move up to the thoracic, the cervical, and the upper extremities. So that's kind of the way these Therex 1 and Therex 2 are kind of built up. Now, I'm going to say one of the things you guys will have at the end of my class is you'll say, well, Mr. McKeever, we didn't do a ton of exercises in this class. I understand that. My class is built to be a foundational class. So you get the idea, we get the lower extremities done, and then Dr. Ovreskin can literally beat you down with a lot of your spine stuff in your upper extremities. And she will, by the time you're done with Dr. Ovreskin, you're like, yeah, I'm really done learning this. Please stop talking to me now. And by then we'll be back in class. So that should be fun. All right. So that is it for the lecture part of it. Now I'll be in that class too. Don't you worry. I'm part of that class too. You don't get out of it. In fourth semester, it's just me and Dr. Ovreskin. That's all you have for that class. You have me and her for neuro rehab, and you have her and then me for Therex. So it's going to be a lot of me and her and me and her. Dr. Soko comes in and helps us with the labs, but I'm talking about for the actual teaching portions of it. All right, so what I'm going to do is I'm going to pause the recording here. All right, so now we're going to talk soap notes. We're back from break. I'm going to start recording again. So we're definitely going to talk soap notes now. Because Diana 100% wanted to cover this, and I know she's 100% paying attention. So we have our soap, right? S-O-A-P. I'm going to kind of give you my way I think of soap notes first, and then we'll talk about what goes where, because this way helped me get through a lot of my clinicals. So when I think of the S, this is what the patient says. And it also is the way the patient presents. And when I say presents, what does presents mean?
Like the physical aspects, what they look like.
Yeah, what do they look like? How did they get here? Right? Did they walk? Did they come in a wheelchair? Like, especially if I'm in the hospital, it's important to know if my patient walked down to therapy or if they had to be rolled down via wheelchair. Right? That's kind of important to document a little bit to know what the progression level is, because sometimes patients will literally walk down to therapy. And that's okay as long as they're safe to walk down, right? If they walk down and they're not safe, that might be a bad thing. We want to stop that. So that's what the patient says or how they present. The O is what's done. So what are we doing on the day? All of our numbers pretty much, except for pain, should go here. So all of our reps, all of our sets, all of our holds, all of our kind of our numeric values go in the O. When I think of the A, I think of this as the therapist's subjective. And I'll explain what I mean by this in a second. The A is how we see the therapy session, how it went. Did we notice any changes? Did we notice any positives or negatives? Did they complete any goals? Did they not complete any goals? Right? Those type of things, those are our subjective kind of overview. So we'll put an overview here. Overview. Overview is better than underwear, right? Overview of how things go. And the plan is, what are we going to do? And when I upload this lecture, what I'll do is I'll actually put a timestamp in the actual YouTube video so that if you want to go back and just review this section, that you can just click on that timestamp and it'll take you to that section of this video. I'm learning how to change things on YouTube, which is really cool. So I'll put a timestamp there so that when Diana wants to go back and review this for her clinic, she can, right? So and I'm going to start at the top. So a patient comes into therapy. Let's say we're in an inpatient world at this point. Patient is wheeled down to therapy by the nurse. That would be something I would put in subjective. Patient presents to therapy today being wheeled to the therapy in a wheelchair by the nurse. And then my pain's going to go there. Patient reports pain, blah, blah, blah. And we'll actually write a subjective out in a few minutes here, right? My pain's going to go there. Patient says that they felt sick. I'm going to put that today the patient reports feeling sick, right? Anything they say, if I am direct quoting a patient, it needs to go in quotes. So like patient says, after yesterday's session, I felt better. I might actually note that. I might say, patient reports today that after previous session, patient feels better. That's a kind of a good clue that they're actually enjoying therapy or that things are going well. They're starting to feel a little better. I may also put their disposition. So meaning, are they grumpy? No, not grumpy. Grumpy is a bad term to put in there. But are they resistant to therapy? Or are they not resistant to therapy? Because that can be kind of important, especially if you're working up in the psych ward. That can be really important. The other thing I put here is my consent. I have a generic phrase I'll put there that I'll put, patient gave verbal informed consent to therapy today. Why do I put that there? Well, because I've had a patient before that said, that the nursing supervisor came around and they're like, that McKeever guy, I don't want to do therapy, and he made me do therapy anyway. And so she took that as I forced therapy on him. But when I noted my notes that they gave me verbal informed consent, that means they said, okay, let's do it. Let's get it over with. That doesn't mean that I did it anyway, despite their objections, right? I told them what we're going to do, and I got them to agree to do something. When you are working with somebody who is under the age of 18, who has to give consent?
Guardian.
Guardian. Parent.
The guardian, right? The parent, guardian, right? So if they're brought with Auntie Sue, and Auntie Sue is not the guardian, we have a problem. We'll talk about that in a second, Diana. That's actually a really good question. You're like going right on along path with me. In the case of a kid, and they're brought with Auntie Sue, and Auntie Sue is not the guardian, there are a couple things we can do. If we know that Auntie Sue is going to be bringing the patient all the time, we may have the parent sign a form that says that Auntie Sue can give consent. Or the other thing we might have the parent sign is just a general waiver of consent, meaning that they consent to 5 treatments. And there are certain laws in different states that say that parents can sign that for 5 treatments, 10 treatments, depending on the state law. And if you're working in a pediatric clinic, they know these things. So don't totally think you have to know all of those. Or the other thing I might do is I'll go out and get little Billy. I'll take little Billy back and I'll call up mom and say, hey, I got Billy here. Is it okay that we go ahead and treat him, mom? And mom's like, yep, go right ahead. Or we can text her, now's today's day and age type of thing. But we do have to get consent even when we're working with little kids. I heard somebody getting ready to ask a question.
Yeah, actually, it's going to go back towards like how a patient feels.
Mm-hmm.
You meant like if it's regarding like a previous visit, let's say, after this visit, I felt better. Would that be a subjective or would that be assessment?
That would be a subjective because the patient said it, not you.
Okay. But if
Right.
it's like in
If
regards
you see
to
them doing better since last session, that would be an assessment of how they're doing. Does that make sense?
Okay. Makes
Yeah.
sense.
Yep.
Thank you.
Good question. So Diana asked, what about a dementia patient? So with a dementia patient, they can't really consent, right? Because they're not 100% there. Or maybe somebody that's got schizophrenia. So power of attorney would be the ideal way if we had that, right? But the other thing is, or what if they're in a coma, right? They can't consent if they're in a coma. At that point, they don't have informed consent. They have implied consent. Could get caregiver if we can get it, right? If we can't, but let's say we've got somebody that lives out in the street, right? We have no access to anyone else, but they're in the hospital. They've had a stroke and they're in a coma. We have no one to reach. There's no family. At that point, they have what's called implied consent. And implied consent means that for their betterment and their safety and their health, they're going to do the therapy because it's good for them, if that makes sense, right? So like say a patient came in and they have a huge blood clot in their brain and the doctor has to operate. There's no family, there's no nothing. At that point, the doctor has implied consent to save their life to do the surgery to remove that blood clot. Does that make sense? Because if not, right? Or say you come up to a person, right? They're choking and they pass out. They can't say it's okay for you to start performing CPR to them, right? But there is implied consent for you to do that in order to save their life. And there's a certain amount of a Good Samaritan clause that goes along with that. The Good Samaritan clause does kind of follow over in clinic, but it's more considered implied consent at that point, right? And I may put that if I have patients' dementia, implied consent or consent given by caregiver, and I may document who the caregiver is, or consent as per power of attorney, like John said. That's a great way of doing it. Or living will, right? I'm going to recommend that if you guys are all starting to get up into your 20s, make sure you have a living will, because I know that you're all young and you think you're invincible, but something could strike you tomorrow that you don't know about. And if you don't have a living will and no one knows what your desires are, family can argue about it, right? So be aware of that. Or if you have a significant other, discuss what your wishes are, right? There's significant others like, well, once that happens, it's insurance. No. Advanced directives. Yep. That goes along with the living will, Riley, to all my dogs, right? All your dogs are going to give consent. Give 1 bark for yes and 1 bark or 2 barks for no. So now we get down to the O here. And like I said, the O is what's done. So that would be where all of our exercises would go. That would be where all of our range of motions would go, all of our manual muscle testing. And I'm going to do we're going to do a sample soap note here in a second, so you can kind of see the way I do them. That may be a little different than the way Dr. Sokel does them. That may be a little different than the way Dr. O'Neill does them. And it'll definitely be a little different than the way Dr. Avreskin does them, because she builds on some of what I do in order to make them harder and challenge you a little bit more. So when you got in the clinic, you're a lot more comfortable on your longer clinicals. What else might go in O? Oh, vitals would go in O. If you're taking vitals with the patient, and you're taking blood pressure, heart rate, whatever you're taking, those would go in the O. If the nurse took vitals, that would go in the O as well. Nursing recently took vitals, C chart, right? That way they're in the chart and they can notice that. I know John said they use a flow sheet or a flow chart with patients. If you use a flow sheet that's separate from your documentation daily notation, and you do this, it's okay in the O to put C flow sheet for today's activities or today's exercises, whatever you want to put there for today's exercises. If there's a separate flow sheet from the notes, some clinics keep a paper flow sheet separate from their electronic documentation, so that you can have something to carry with you to go out to the floor to treat the patient with, right? That still has to at some point go into the record, whether it's scanned or however it's done. But maybe you have a separate flow sheet, or maybe like in WebPT, which is one of the softwares we have out there, there is a separate flow sheet that you access from the note. And it's okay to put C flow sheet for today's activities. If you make any changes, you're going to document them on the flow sheet, but also put in the O, increase to green TheraBand with external rotation today, or added, anterior pelvic tilts to flow sheet. Any changes you make, you want to make sure you're documenting, right? So please make sure you're always documenting your changes, because if you don't document your changes, somebody may not be able to follow you. Or maybe you canceled an exercise, lateral trunk bends on home exercise program. If you teach them the home exercise program, that would go in the O, because that's something you're going to teach them. Now, when we get down to that A, this is probably the trickiest and the hardest thing for students to get. Would you guys agree that the A is kind of the hardest thing you guys are having trouble with right now? And say, yeah, right? That's kind of the hardest. The A is going to be, I'm just going to start erasing so we can start working on stuff. The A is going to be kind of some of the stuff you see. So let's say when your patient started therapy, they were at a 9 out of 10 pain. And now at the end of therapy, they're at 4 out of 10 pain. That gives you something to document and know. And all you really have to put there is, after today's treatment session, patient's pain in right shoulder decreased. You don't have to put how much. You don't have to put that it went from a 5 to a 2. You have to put that it went from a 10 to a 6. You just have to put that the pain after treatment today decreased.
That's an O, you said, or A?
That would be an A.
Okay.
That's an assess. That's something you assessed, right? Even if they said, oh, my pain got better today, that's fine. Right? But you're still seeing that their pain got better, right? Because you can tell, right? Or maybe you notice that they're having less difficulty getting out of the chair after therapy. That would be something you could put in A. It could, yeah, right? Riley says, could you think of A as an evaluation assessment? Absolutely. That's what assessment really means. And in some states, to be 100% honest, PTs don't even want PTAs doing A's, because they consider that an evaluation. I know for a while in Indiana, the PTA soap note didn't have an A. So you didn't even have to worry about it. It only had an SOP. because they didn't want you. They said that 1A is way too close to what a PT might do. So we're not even going to let PTAs do A's. We're just going to have them document what the patient said, what they did, and what's going to happen next session. Right. But yeah, so exactly, Riley, is that it could be thought of as an evaluation in session. What did you see happen? What changed? What didn't change? Right. Maybe you went through the whole session and nothing was different from the last session. That would be an assessment to make, right? Patient presented with no changes in overall pain or range of motion today. That would be an assessment, right? Patient completed short-term goal 1. That's an assessment because you have seen them complete it and you have assessed they've completed it, right? If they've completed a goal, that means in your plan, you're going to have to put that the PT has to add some new goals to their treatment, right? So in the plan, it's what we're going to do maybe next session, right? Maybe we're going to increase the TheraBand from green to blue. Maybe we're going to add pelvic tilts next session. That's kind of what the plan is. So in the olden school days, when I grew up, back when dinosaurs roamed the earth, I'm going to actually get some text because I think typing is going to be a little bit easier for me here. You would see stuff like this in the A. Patient. Oh, let me have fingers up here on the keyboard. There we go. Am I on the right keys now? There we go. It's a little awkward angle. Tolerated treatment session well with no concerns or something to that effect. What does that tell you?
Nothing.
Yeah, it tells you nothing. Yeah, it doesn't really tells me nothing. All it says is they were able to tolerate the session. That doesn't tell me squat. Now, if they, if I put on there, patient tolerated treatment session well and was able to complete all exercises with minimal increases in pain. Now I've added some more information to it and they're able to kind of deal with that a little bit. There's a little bit more there to it, right? There's a little more teeth to it. So that's the thing. You have to be kind of specific in this. With no concerns doesn't really tell me anything. And this is what I loved when I saw plan. Here's one of my favorite plans of all time. I'm sure that John probably has seen this one. Continue treatment as per plan of care. Has anyone ever seen that in a note? Wow, that's prophetic, right? Again, if we just keep doing the same thing over and over again, right? The good old definition says that's insanity. Now, does that mean that we maybe don't change much between sessions? No, sometimes we have nothing to change, right? But if I have nothing to change, I can put down their review home exercise program. It does look like a text message, right? It looks like a bad text message is that you get your text message and you're like, what is this person trying to tell me? Right? Now, maybe I might say, continue to review their home exercise program next session. That's good. That gives me something I'm going to do next session. Add TheraBand external rotation next session. That gives me something to do next session. Consult with PT about adding a new goal. Okay, I'm actually going to talk about that. It's a great comment, Amanda. You want to be specific, John. So John asks, how specific do you want to be? You want to be specific, but you don't want to write a book. Right? Because at some point, if I follow you, and I had this clinician back in Pennsylvania, great guy, fantastic patient care, great guy, but my God, he would write 4-page soap notes for every session. And at some point, like you'd look at his soap note and be like, no, just not reading it. It's not happening. Right? So you have to be aware that it has to be specific, but not too specific. And that's going to take some skill. You have to practice that. So Amanda asked, is RX treatment or is TX treatment? I'm going to say yes. That's my answer to that. Right? So it
Yeah, 'cause
depends.
I thought I remember Dr. Ruskin saying that RX was treatment, but
That's what I'm gonna talk about. Some clinicians say that RX is treatment. In my world and everything I've ever encountered in my nasty kind of healthcare world, RX means prescription. And TX is treatment. And this is going to seem kind of really petty, but in the clinics where TX also meant traction, if it meant traction, it was all lowercase. Or we just didn't use it. But I'm going to be 100%, I'm going to be 100% honest with you. Most clinics, I've never seen them use this for traction anymore. Almost all the clinics have stopped using this and TX is now treatment. But let's say next semester, Dr. Reskin says, in my class, RX is treatment. That's where it comes down to working at different clinics. That's when you go, exactly like Amanda said, copy, got you, Dr. Reskin, RX is treatment in your class. Got it. In my class, I don't care what you write, but I would prefer you to use capital T, lowercase x for treatment. Because that's what I've used in every clinic I've been in. That's what I saw on some of your boards. So, you know, it's you'll be able to tell if they're talking about a prescription or a treatment really easy, right? Because if it says continue prescription as per plan of care, that doesn't make too much sense. Right? So if you're in a clinic that uses RX, great, use RX. But in most clinics that I have ever been in, TX is treatment, but it's capital T, lowercase x. So that's a great question. And that's going to be one of those that may be different. I've been in clinics where they don't like you to use R with the circle, L with the circle for right and left. They want you to write it out. If it's on the boards, I'm going to tell you TX is probably treatment. I have yet to see a question in the prep classes or prep tests where TX is written out and it's for traction. But how could you tell that? Well, if it says spinal TX, then you probably know it's what?
Traction.
Yeah, context clues. Traction, yeah, right? Where if it's talking about what the patient did, that's probably the treatment. So yeah. So just kind of using your context clues helps there. The other one I've seen that some of the clinics don't like is, let me get my eraser here so I can have space. And I don't know what the reason is for this, but the abbreviations for bilateral are either bilat or B with a circle around it, right? I know some clinics that hate that. For whatever reason, they really don't like writing out bilat. It's B with a circle only. If that's the case, that's what you use. That's when you go again, like Amanda said, copy, got it, move on. In my class, if you turn in a SOAP note and you use RX for treatment, am I going to mark off? No. Dr. Reskin may, because she's pretty particular about that is what she wants. RX isn't or prescription is treatment, right? That's okay. If she does that, do what your boss tells you to do at that point, right? But I'm telling you, I'm pretty liberal on my abbreviations as long as it's an approved abbreviation. I've seen some people writing VIC for verbal informed consent. I have yet to see that as an approved abbreviation. I don't take points off if you write that, but I usually write beside, may not be approved. I think this comes from some of the ATI clinics, maybe. I'm not sure. Because it seems like the people that I've seen that are techs at ATI seem to use VIC. And it may be because they're seeing that at ATI. I don't know. And I also saw it at some of the people that have been techs at Health South. but just be aware that's not an official abbreviation. But if your clinic uses it, clinics may have their own specific abbreviations. If that's the case, you do what your clinic does. What I would take off points for is if you just completely use the wrong abbreviation. Like if you meant, what does P with a line over it mean?
After.
After, right? And you actually meant before. That's the wrong abbreviation, right? What's before?
A.
A with a line over it, yeah, right? That's before. So if you use the wrong abbreviation, yeah, I'm gonna get on you a little bit about that, right? If it's a totally wrong abbreviation, if it's this RX or TX, I might just write a little comment on your SOAP notes because you guys are gonna do a couple SOAP notes for me.
Mr. McKeever, I know we're not quite at this point, but I was curious, like with goniometry, if there's a difference in measurement, like at the end of a session, that would be an assessment, right?
That's actually what I was going to cover. You guys, it's getting scary. Get out of my head. I was where I was going right now. I was just clearing up some space for that. So, because I was going to try to use to help out, kind of clear up assessment. So let's say that you did right shoulder flexion. Right? And today they went from 0 to 120 degrees. And there was no pain noted. But last session, I'm going to change colors here real quick. On the previous note, this was 0 to 75 and pain was noted. So there was an asterisk after it. Now you have something to write an assessment. So now I could come down here to assessment and say, patients, right shoulder flexion. And actually let me switch to type because otherwise you guys won't be able to read anything I handwrite out here. This is why I should have been a doctor, right? Because I can't write for anything. Actually, writing with a mouse is harder than it looks. So I could write an assessment here. Patients, right? And I can't make a circle right now, but I'm just going to pretend like I put a circle around it. Shoulder flexion increased over previous session and with reduction in pain, or with no pain, you could even put there. That's an assessment. That means you looked at the previous session and you had 0 to 75, but this time you got 0 to 120. Now there's a million different ways you could write that. Right? So that's not the only way you could write it. You could just put patient's right shoulder flexion increased versus last session. That's okay too. Right? As long as you're conveying, hey, I looked at last session, he was here. This session, he's here. You don't have to write increased by, what would that be? That'd be 45 degrees. Because and again, remember, we're writing a lot of this for the person that's going to follow us, or also for medical insurance. If the medical insurance wants to see how much that range of motion is increased, they have all the notes. They can go back and look at that. And actually, in a lot of electronic documentation systems, if you put that new value in, so say you go in and you put this value of 120 degrees in there, a lot of times it'll put a parentheses in here and it'll say plus 45 degrees. And what that plus 45 degrees is over the last session. Right? So it'll tell you kind of the patient got a little bit better. And that gives you something to definitely put down here. Right? Let's say instead of dealing with, so we dealt with a lot of range of motion here. Let's talk about gait. So let's say the last session, I'm going to erase that. I'm going to get my text box back up here. So this session, patient ambulated 195 feet times 1. We're going to break this down here so that you understand. Don't freak out yet. From a walker, normalized pattern. So what I wrote here is patient ambulated 195 feet with a front wheel walker, FWW. What does min A times 1 mean? What does that mean? Does anyone have a clue? No idea. It's okay. You're going to hit that in rehab. I'm just giving you a preview. So min A means minimal assist, meaning you're providing them with a little bit of assistance. Basically, it's going to be less than 25%. So they're doing 75% or more of the work. This may be you're just kind of keeping a hand to hold on them, kind of helping them balance, keep going. Times 1 means how many people help them?
Just the one?
Just you. Yeah, just you. Right? Say that I'm working with a patient and Diana is my tech. And we have 2 people working with her. Now I could say minimum assist times 2 because Diana may be following with a wheelchair. Right? Second person may be following me with a wheelchair. That would be still times 2 because 2 people are helping the patient. Right? So min A times 1 means you're helping them a little bit. They're doing most of the work, but you're there. Normalized gait pattern means that they're trying to hit heel toe, heel toe, heel toe, heel toe. We're not doing any special gait pattern. But let's say the last session, they only walked 75 feet times 1. Is that a change?
Yes.
That's a big change, right? And again, if you have some electronic health systems, that may say, wow, this is plus 120 feet. Now, the 195 feet times 1, what that means is they got up in one go, walked 195 feet without stopping to take a break. They may have turned around. They may have walked straight 195 feet to go down to OT or something like that. I don't know. But they walked it in one go. They didn't take a break. That includes, they may have walked, 87 feet that way and 90 feet this way or whatever, added up to be 195 feet, as long as they took no break. If they take a break, that break will then split it up into two gait sessions. And we'll talk about that in the future here. But this is definitely a difference. So I could come down here and I could indicate patient ambulated increased distance today over previous session. That gives me an assessment. That is clear and concise. That is saying, yeah, they definitely changed it. Does that make sense? That start helping make clear up assessment a little bit for you guys?
Yeah.
Yeah. And so don't totally freak out that this is the only session we're going to have on SOAP notes. We're going to have a little bit of session on SOAP notes after most lessons at Therax, because that helps get this kind of in your process, and you're going to write some SOAPs for me so I can correct them and give you some feedback on them. The other thing is maybe last session here where we're talking about the 75 feet, maybe they did it in parallel bars. Oops, that's wrong key. And now they're using a front wheel walker. That's a change too, right? So now they're using a lesser restrictive assisted device, right? LRAD. So you can put down there in the assessment, today patient walked with front wheel walker versus parallel bars last session. That's a pretty good assessment. That shows they are showing improvement. Again, your assessment is a good place. You tend to avoid numerical values in assessment if you can. Right now, what if your clinic, say you go to, like, I know one clinic in particular in town, Concentra. Does anyone know what Concentra does? What's Concentra known for?
Workman's comp.
Workman's comp, good, right? They tend to put numbers in assessment. If the clinic does it, you put numbers there, right? But almost every clinic I've ever been in will say, no numbers in assessment. Stop putting numbers in assessment. Even if, like Truman asked about, or Anthony asked about range of motion, I can just put patient shoulder flexion increased today over previous session. I don't have to put what the number was. I can just put that it got better. Because again, if I really need to know how much better it got, I can look between the two notes. Does that make sense? because there has to be some clinician kind of thought process on it. We have to do a little bit of work, folks, is what I'm saying. All right, does this kind of start cutting your teeth a little bit on doing soap notes? Again, we're going to—
Thank you, Mr. McKeever.
Yeah.
That was great.
Yeah, don't worry. We're going to do lots more of these, so don't think this is the last one. All right, guys. Well, it is about 10 of. Are there any other questions I can answer before we kind of wrap up today?
I have a question, not really regarding the soap note, but when a patient comes for an eval, a speech pathologist or like they also help with their like, okay, so wait, let me rewrite that. Okay, so when the speech pathologist, they're part of the evaluation with the PT, correct?
They could be, but the speech pathologist is going to write their own eval.
Okay, so when they go to therapy, does OT or PT do that? Like help them with—
What depends. I mean, typically if they're, I mean, it's pretty rare that we're going to do anything speech related. They may ask us, they may say, hey, you know, they're going to see the speech, and actually there's now an SLPA as well, just like there is a PTA and an OTA. There's the first program I think opened at Northern Arizona. I want to say Northern Arizona University for speech language pathologist assistants who are going to do all the treatments that the speech language pathologist writes up, right? Because again, just like we're in our world, speech language pathologists have to do so much paperwork, they're not getting through treatments. But I have had an SLP say to me, hey, you know, when you're working with the patient on getting out of bed or walking, can you help them and have them verbalize while they're walking to do some cognitive work? Sure. Right?
Yeah.
The PT will put that in the note and part of their goals, right? They may tell PT that. PT will put that as part of their goals. We'll do that as part of their treatment session. But primarily, the SLP is going to keep seeing them for SLP work.
Oh, okay.
Yep. Any other questions for today? All right, so I'm going to stop